Thank you, ladies and gentlemen, for coming for the October 28th Siac meeting. Thank you for all of our vendors and everybody that's here today with us. Let's first look back at the minutes for September. Is there any discussion? Yes, ma'am. Please speak into the microphone. I think they were on.
They were? Okay.
Mm-hmm.
Yes, my question is for Mark.
Yeah. Mm-hmm. Go ahead.
In the section we were talking about trauma awareness training and what the teachers had and pre-planning, Mark, you said you would get back to me on getting that available to all support staff. I haven't heard anything. Do we have any follow-up on that?
I don't right now, but I will get back to you, Leslie.
Okay, thank you.
Is there any other discussion of the September meeting's minutes? If not, do we have a motion to approve them?
So moved.
And a second?
Second.
All in favor?
Aye.
All right, let's
That
move
was
on.
by Chris, and second by Dominic.
For those of you that are joining us on the Zoom call, we wanted to make sure that in order for you to hear everybody else, you need to live stream the YouTube live stream of the meeting, and then you will be able to participate with us by speaking through the Zoom call. Okay. All right. Let's go ahead and get started with our first thing on the agenda, our financial update.
What'd you say to hit?
Just use your mouse.
Okay, here we're looking at 3/4 of the financials. Okay, we're looking at 3/4 of financials. We have 3 complete quarters. You can see, if you're looking at the revenue, you can see the difference between quarter 1, 2, and 3 is 2 had the accrual and quarter 3 had the reverse accrual. Quarter 1 is about what we normally run. The total admin costs, it looks a little low in quarter 2, and the reason for that is we had 2 Cigna Premium holidays hit that. Quarter 1, we had 1 Cigna Premium holiday hit. So quarter 3 is about what we usually run in admin costs. Going down to pharmacy costs, that looks pretty steady across the quarters, but just to remind you that we had rebates hit each quarter. In quarter 1, we had $731,000 worth of pharmacy rebates hit. In quarter 2, $1.1 million hit. And in quarter 3, $1 million hit. And so in quarter 4, I expect another $1 million to hit. We had a loss of 7.4, and that leaves our fund balance at $5 million. Looking at last year, we had a loss this time last year of 8, and our fund balance last year was $9 million.
Do you have any questions? Go ahead, Anthony. Make sure you speak really close to the mic because they're having a hard time hearing us on the YouTube feed.
Okay. So I'm noticing this is now being reported in quarter 1, 2, and 3 rather than monthly, and I believe quarter 3 ended in June. Why don't we have, I mean, it's almost, is it September?
It's September.
September,
Yes.
okay. So we don't have October, well, we're still
still
in
in
October.
We're still in
Okay.
October.
All
So
right.
what I've been doing is I show the monthly until the quarter ends, and then because of space on the paper and you know how the numbers get so small it's hard to see, then once a quarter's over, I usually reduce it to just a quarter. So this is 3 complete quarters.
Okay. I had another question
Yeah.
too. So I wasn't here last month. Looking at the minutes, I see there was a $2.5 million infusion to bring the fund balance into range.
That's right.
So
need part of it, just so we can report to the insurance regulations. And we did report, and we got an acceptance back from them, so we're cool for June.
Thank you.
Okay.
Any other questions for Ms. Doss? All right. Thank you very much, ma'am. All right, we've had a request to move the agenda around just a little bit. We're going to invite Jim Sink and Laura Manlove to come on up and give us the Well Care Center audit follow-up. So we're reversing 4 and 5.
Hi, everyone. Thank you for inviting us back. What? Thank you for inviting us back. Can everybody hear me? My name's Jennifer Murtha. I'm here with Laura and Jim, and we're here to do a follow-up on the report that we did. One of the things that I wanted to clarify was that this report is dated June 25th. So it is a little bit older for us. So if we have questions that we don't know off the tip of our tongue, please bear with us. It was a little bit ago, but we also have Matt Wolf on the phone who hopefully can dig through some detail and answer that. One thing I wanted to just clarify, in some cases you guys have used the term audit, but this was actually not an audit. Although we are internal auditors, we did not audit the data. This was more of an analysis at the request of the superintendent through the audit committee, which is what we report through, to perform an analysis to determine some cost benefit and some return on investment. So if everybody could kind of keep that in the back of their mind, particularly when it comes to the numbers, we utilize the data that you all receive on a timely basis, on a monthly basis, and quarterly. We utilize that information. Our experts, Jim Sink is here, so we don't have any technical difficulties this time when we have questions. And we use that information to analyze the wellness. So I'm going to turn it over to Jim. Laura's here. You'll recognize her from last time. And off you go.
Thank you. I am Jim Sink, as advertised. I am a healthcare partner for RSM. I've been with the firm for going on 22 years. I specialize 100% in healthcare, work very heavily in the provider space, and some of that experience and knowledge I think carries over to some of our other clients like this one. I also have on the phone one of our eminents, industry analyst, as we refer to externally most of the time, Matt Wolf. Matt is in a select group of future leaders. Some of them are partners now, but started out sometimes as managers and directors, where the firm has invested in them to really understand the core issues that impacting our clients. Matt had played a heavy role in the data analysis for this project, and I understand that there was a question that we wanted to follow up on in this meeting. Is the person who asked it, are they here today? Okay, because I want to make sure that.
I don't think so. It was Jeff.
No, I think it was a good question. I'm impressed by the level of critical analysis to pick up on it. But we brought Matt because he actually did the analysis. I think it's a pretty straightforward answer. Matt, can you hear us okay? I know you were saying that you had some challenges hearing earlier when we were testing the mics. Can you hear? Matt Wolf, can you hear? I can answer the question if he can't.
Is he muted?
Matt, are you muted?
Say something if you're muted.
Okay, now ask.
One more try. We may have had you muted. Maybe. Matt. Testing. Going once. Twice. Okay. Well, maybe we'll go ahead and proceed. All right. If you can hear us, Matt, thank you for dialing in. Okay, so I don't know, was everybody here during the last meeting when there was a question asked again, great question. So if you go to the dashboard, get the right page here, page 14. One of the things we talked about that when we did the analysis, it just sort of as a summary and a recap.
Did this work?
Yeah.
Yes, we can hear you now.
Yeah, so let me, Matt, we can hear you now. Try one more time.
Okay.
Oh, perfect. Let me set it up. I'll ask the question and then I'm going to let you provide the answer because you're deeper into the data and maybe have some additional clarifications that you'd like to make. But as a recap of the analysis, hopefully everybody knows we were asked to evaluate marathon data to really sort of objectively evaluate whether we thought that the program was showing effectiveness, justifying the expenditures that were made. And so we carefully evaluated all of the information that was available to us. And I think the general theme is that we do think that the program is having a positive impact based upon the information that's there. We would probably analyze the information a little bit more in a more targeted way. And I think that one of the conclusions that we probably talked about last time is that we think that we probably should be more focused at improving engagement and in a more targeted way. And we'll talk about that a little bit more here in a few minutes. But the question that was asked last time, which sort of correlates with some of that, was that if you look at the center column of the comparative analysis, there is a cost per eligible enrollee that's highlighted there. And the person that raised the question in the audience noticed that correctly that there was about a $3,000 differential between the non-engaged and the fully engaged employee, the ones that are using the wellness clinics. But that we, to the right of that, we indicate that engagement is at 40%. So the intelligent question that they asked was, why isn't the average higher if only half of the people were fully engaged? And there is actually an answer to that. So I'm going to leave it off there, Matt, and maybe you can talk about the way that Marathon evaluated engagement and how that correlates to this calculation.
Yes, happy to, Jim. Thank you for allowing me the opportunity to expand a little bit on this. So the way that Marathon, as Jim and Jennifer mentioned, reviewed and did some of our analysis on, was they grouped the patients in two buckets for purposes of this calculation. Sort of the non-engaged, which meant that had not utilized the coaching visits at the wellness centers at all. And then what Marathon called the engaged members, which used 2 or more coaching visits. And then they broke down kind of by site of service that average cost between those two groups. And the sites, if you're curious, inpatient hospital, outpatient, emergency room, home, and then a smaller bucket of other. The average cost for the non-engaged on a kind of chronic adjusted basis per Marathon was $8,759. For those members who use 2 or more coaching visits, the average cost was $5,685, a difference of, $3,074, which for some of our analysis, we rounded there, you can see about $3,000 of estimated cost savings. And now I understand there was also some questions around sort of the 17 versus 40% versus 83%. And so I can expand on that a little bit too. So if we look at the engaged, sort of the highly engaged, this 2+ coaching visits, approximately 17% of the total member population. Now, 40% of the members per marathon had used a coaching visit. But, you know, if we look at the net, right, 17 versus 43% versus, 40%, what this means is that 23% of the members fall in between those two buckets. They are, because they have used a coaching session, but they have not used enough coaching visits to be considered engaged for the purposes of the $3,000 calculation. The 83% number comes from the, you know, kind of feasibility, and I don't know that's the exact right term for it, but really the feasibility study that was done, you know, years ago before this whole endeavor started with the wellness clinics, where 83% of the members said they would use or be willing to use or consider using the wellness centers and get coaching through those wellness centers. So what that means, the way we looked at it based on the data presented to us, is that 83% of the total members expressed interest in using the wellness centers. 40% of the members had used it at least once. 17% were engaged, meaning 2 or more coaching visits. And cost between those engaged members and the other 60% who have not even used it once was about $3,000 per year.
Any questions about that? I would say, reflecting
Any
on... Oh, go ahead, Matt.
questions?
Sorry.
Does that help clarify that part of the analysis?
Since Jeff isn't here,
Yeah,
Yeah, no.
the person who asked isn't here. Does anybody have any questions concerning those numbers? Everybody should be unmuted.
Okay, all right. While you're doing that, I'll just comment on something. I would say with hindsight that I think it would have been a better reflection if we would have used the 17% on the dashboard. I think it would have been more understandable. But I think it also highlights the opportunity. Because really, I think the additional 23% that are in that 40%, the fact that they've gone to the wellness clinic a single time, I don't think is evidence that they're really getting the value from the wellness clinic program. I think it's really important that the wellness clinic, for it to be effective, that they develop a very strong patient, physician, or clinical relationship, so that you can really have an impact on some of those preventive opportunities that can bend the cost curve. So I think it only sort of reinforces, I think it makes the argument greater. The other thing, Matt, I think that you pointed out earlier too, just so, and it's probably getting in the minutia, but just in case somebody afterwards looks at it, the 17% of the people that have used the wellness program 2 or more times versus the 83% here that are willing, those two numbers do not correlate. Those are two different numbers. It's just a coincidence that they add up to 100%. So I think I asked that question, and Matt pointed that out. Matt, were there any other points that you wanted to make?
actually, let me ask,
Sure.
if anybody on the line has any questions, I think you can just unmute your computer and ask the question. If there's anyone that's listening out there that has a question, you can unmute and ask that question.
Because Mr. Bailey's not here, but can you explain that average? Because I think that's what he was asking. Why is it skewing
Yes.
lower? What is?
Yeah.
Can you explain the
Yeah.
average
So,
number in the middle?
Matt, do you want to take that, or do you want me to try to do it? Did we lose you? No worries. How do I do that? Hang on, Matt. Bear with us. Bear with us.
Yeah, it keeps
Oh.
muting itself.
Okay, got it. Matt, can you hear us, and can you talk now? We think we may have had you muted.
Yes.
Okay.
Yeah,
So
I'm
do you
here.
want to
No,
take,
I have to
so
juggle
why
with-
don't you explain again the math on the cost per enrollee between the engaged, non-engaged, and then the average, to make sure that that's the question, right? That you wanted
It's yeah.
to be
Explain
repeated?
that middle column, the
Yeah.
average.
Okay.
Yes. So the average, the $6,180 is the, and this, that average of $6,180, you know, the cost savings for people that use the wellness centers one time, but don't, you know, aren't categorized as engaged by Marathon's definition of using the coaching sessions 2 or more times. So we can see this is showing is that per the data provided by Marathon, there is a significant cost savings when members use the coaching services at the wellness clinics 2 or more times, around, call it $3,000, really per this analysis, $3,074. Call it $3,000 in average annual savings for people who use the coaching services 2 or more times.
Okay, so hang on.
This
Stop,
average savings
stop.
is meant
Yeah.
to
Matt,
highlight that even
Matt,
for, oh, go
Matt,
ahead.
Yeah. So
Stop.
I know there's a
Hang on.
delay. So
Wait.
we do get that.
The average is meant to show that even if there's
Hey, Matt.
some usage
Matt.
of the wellness clinics at the
Matt.
That's okay. I think he's getting
there
there.
is still some demonstrable savings there
Okay.
as well.
So what you're saying is the middle column is not actually an average of all members, but is actually that represents the 40% who have had at least one or more visits.
The number is actually 17%. That's the confusion, I think.
Right, but you said in 17 is the far right column, the engaged. I think what we want to know is what does that middle column represent?
Oh, that's the weighted average, right?
Okay.
That's the weighted average, and the reason why that the weighted average, right, between the engaged, which is the 17%, and the non-engaged, which is actually a different 83%, right? The reason it's not closer to the middle in the numbers, closer to the 8759, is because only 17% are represented by the 5685. So it's the weighted average.
But the average are people who've gone to the clinic once. That's what I heard him say.
Was 40% is what I heard.
So Matt, do you want to clarify that? Make sure I'm not confusing them? Did we lose him again?
No, there's just a significant delay. You'll hear us about 1 second.
And Jim,
Yes.
if I might cut in here, I think that this might be. No, and I think this is one of those. It may be helpful just to provide. Did I get muted again? No. Okay. Might be beneficial to provide some of that actual underlying data, that calculation as a follow-up document, so that everybody can just have it in front of them and see
Yeah.
it, and we can do that as a takeaway.
Yeah, we can do that. So you and I discussed this extensively. So, but I'm going to state this, and it's okay if you tell me I'm wrong. Okay. All right. So I'm going to restate what I just said, because Mark picked up a difference in what he thought you said versus what I said. Right, Mark?
Yeah.
Okay.
I heard him say that the average are people that have gone to the well care centers one time, and that those who've gone engaged are at least 2 or more visits. That's what I heard him say.
So, did you hear what Mark just said? The lack of correlation between the 40% engagement, right, and the average of 6180, based upon our discussion, my understanding of that was that the reason that average isn't closer to the 8759 is because it really wasn't 40% that was used in that calculation, but that really represents 17%.
Would you please?
He's listening to everything you just said.
wait for him to come back.
I think I like your idea, Jim, just to move things along, of coming back with a more detailed analysis.
We'll provide you
Yeah.
the data. I'm feeling pretty confident that I'm
Okay.
saying it right.
Okay.
And it's possible that maybe he said it differently, or at least said it confusingly. But that explains the why it doesn't correlate. If it was 40%, that average would be higher,
Right.
right?
I
The
think
reason it's
that's-
not is 'cause it's only 17%. But I'll get the data, we'll show you the information. If I'm in any way off base, I'll admit it. Okay? So any other questions before we go to the recommendations?
I think we're ready.
Okay, all right. So based upon the information that we reviewed, we believe that it does provide enough information to suggest that the investment in the wellness program is effective. However, and we think the conclusion probably should be not to abandon the program, but to double down on the program, which is really in alignment with the national trends, with the major programs. I do a lot of work with the Medicare and Medicaid programs. A lot of the incentives from the Affordable Care Act are really focused in the same directions, and I think that the empirical data outside of this setting suggests that investing in preventive care and wellness programs is the right thing to do. So it doesn't. So going with that bias, but being willing to observe whether that's not happening here. The data doesn't suggest that it's not happening here, but the data that we reviewed, done in the way that it is, could have been done differently for it to be more conclusive. So we believe, again, to restate myself, that doubling down is probably a better strategy than walking away. Now, what does that mean? So if you're currently if the real number is you're at 17% engagement, or if you like the 40% number, either way, I think the conversation is really the same. How do you improve engagement so you can get more benefits and bending the cost curve as you move forward? And really in that very first recommendation, I think the major thrust, the point of that is, do you focus on the population at large, some of those representing little opportunities to really have an impact on cost, and some of those would be greater opportunities. I read a statistic last night. I was perusing some other information for other reasons, which I thought was really intriguing, that everybody probably is aware that cancer is the #2 mortality risk behind heart disease nationally, but that 1/3 of all cancers are avoidable through diet and exercise. I actually hadn't seen it written that way. 1/3 of all cancers avoidable through diet and exercise. Another 1/3 of all cancers are avoidable if you don't smoke. So, I mean, those are really simple behavioral changes, but they're hard behavioral changes, right? Simple in concept, hard to implement, requires a very strong, I believe, clinical relationship to provide people who have different, there might be different reasons why different demographic groups are less likely to follow those behaviors, but gives us an opportunity to really try to have an impact on those behaviors. But if we're going to try to focus our energy, in performance improvement work that we do, it almost always comes down to the 80-20 rule. Whatever we do, whether we're doing revenue improvement work, cost reduction work, we look for the greatest opportunity to make an impact. It's probably what you do too when you're trying to educate students, I'm guessing, right? I mean, it's kind of common sense, but you'd be surprised that as long as I've been doing this, that we keep doing the same thing over and over again with our same clients and different clients. So if you apply that logic to this particular situation, we really ought to be, before we start developing strategies to improve engagements, we think we should be very targeted in how we do that. And not that we can't try to have some strategies that provide access to everyone, but we really ought to be looking for those risk groups that we think have the greatest opportunity to make an impact, that may be the most receptive and maybe have the greatest clinical risk, regardless of the demographic or other factors that are taken into account. So we would create a static analysis. Effectively, when I say that, I just mean we would start going forward. We would look at the data, we'd break it down, we'd analyze your clinical data, we'd understand your cost per enrollee by those different risk groups and those categories, and then use that information then to decide how do we get them engaged. And based upon that information, it might impact how you do that. So that's really the point of point one. Any questions on that? Is that okay? Okay. I think I covered point two in that discussion as well. I think really kind of covered both of those. And I think I covered point three, but I would create dashboards. I think the point of point three is that I would create management dashboards so that that are consistent. Again, something that we do with most performance improvement engagements, especially in today's world, with all the data available and digital transformative things that are happening within the market. We try to measure our performance using consistent measures that we think are going to measure our progress to the outcomes that we're trying to achieve. So in meetings like this, you could look at them very quickly, efficiently, to say our strategy was to improve engagement in these targeted areas. These are the things that we are doing, and we can measure execution for those things to improve engagement, and then we can measure our progress both with the engagement, but also how the impact that we're having on that cost per engaged enrollee within those clinical categories. So I think that's the major point of point three that we have there.
Can I interrupt, please? Miss Butterfield's on the line, and she's tried to ask a question. We can't hear her.
Please.
She
Don.
wants to ask, can Marathon state what the best scenario would be to determine engagement? What is their ideal definition of being engaged?
I'm just going to wait a second to make sure. Do I need to wait for her to hear that?
No, she can hear.
Okay.
Yeah. Okay. Ms. Butterfield, you can try to speak again. You've been unmuted on our end to maybe try to speak again. She's typing feverishly. She's looking for some kind of concrete number. You've been unmuted on our. We can hear you, Don. Can you hear us?
I think there's a lag, but I'll try and catch up. So I think you guys can hear me now. So I guess the question is not necessarily our plan and how effective it.
For some kind of concrete number.
Well, yeah. Tina's perspective, anyway. The return.
We can hear you, Don. Can you hear us?
I can. I'm going.
There's a lag, but I'll try and catch up.
Okay.
So,
I'll quit. Okay, I'll quit listening to YouTube because it's anyway. So from Tina's perspective, it was a true ROI, not necessarily how effective the clinics are. And if you look at, if we're already starting from the 83% at the beginning said they would use the clinic, if you compare that to who it, I'm not sure that we can define this as a success. But, and I understand the interesting points that have come out of that is engagement with some sort of something. I mean, I think it was in the analysis from the from RSM that there are other ways to, get the healthcare system. Maybe that's something to look at. But from Marathon's perspective, I wonder, from our plan in comparison to the other plans that they have, what would be a reasonable targeted number? And like if it's 75% and we're at 58, what would that number be? How close are we? And then the third question to Marathon would be, what besides what they have, they do extra to get more people engaged?
I think those are good questions, and I think it'd be great to hear their response to that. And I think your point to calling it a success, I think it depends on the metric that you're evaluating. I don't think anybody would probably say that if the engagement level is 17%, that's a success, because there's so much opportunity for improvement. But I think the question that we were trying to answer is it having an impact on the cost curve even at 17%, or if you want to call it 40%? Is it making a difference? And the data that we looked at, that Marathon put together, suggest that it is actually having an impact to some degree. And when you compare that with the other data, and we think there's probably a better way of benchmarking as well. I mean, the best data available that we were able to use to benchmark you against others was Southern U.S., which may not be perfectly comparable type data. And there's some other ideas we have in that regard that we could talk about going forward if you'd like. But it suggests that even your cost began below cost. The cost appears to be increasing at a rate much slower than the rest of the market, both regionally and nationally, which is really the only way that you can measure. And it's very, I mean, it's theoretical, but it suggests at least that you didn't waste your money on the money that you spent. And I think you should feel good about that. But I think you should also feel good about the points that you're making, Don. I think there's tremendous opportunity for improvement. And I think that those questions to Marathon would be good questions to ask. Okay. So the final bullet point, we think, after you've done the analysis and you evaluate who you want to engage and where they are located, earlier in the conversation we had discussions with some about access, that you know, teachers, you know, may be 50 miles up the coast. There's logistical challenges to getting away from school, getting to the wellness clinic, doing all of that with all of the other activities that they have to do. I think those, you know, that's legitimate. But after looking at the data to understand who it is you want to engage, where they're at, then it might make sense to then develop strategies on how to provide access. And rather than jumping immediately into a bricks and mortar strategy, if that becomes part of the discussion, we think embracing telemedicine and technology is something to think about. And I mean, all of us are probably being touched by telemedicine. I personally had never had a telemedicine visit until the last 60 days. Best doctor appointment I ever had. Never want to go back to the doctor in my life unless I'm dying. So, but I think that I think leveraging technology and digital opportunities to create access and connectivity might be a more effective way to improve engagement with many populations. And I know that this correlates with a whole nother topic that's actually similar that we're having with the provider industry. Just real quick, because I want to make the parallel. The Affordable Care Act made available what they call a Medicare wellness visit for senior enrollees, right, on an annual basis, but they're having a hard time getting engagement there too. And there's a number of reasons why that is, but one of the ideas is to use telemedicine to do that as well, to create that connectivity. And so I think this parallels conversations that we're having in healthcare in a broader context.
Just to let you know, Marathon is doing telemed in a big way at this point. So a good portion of their appointments, both coachings and others, are telemed through them as well at this point.
So it may simply be, rather than in earlier discussions where I heard some brainstorming about creating clinics with greater access, it might be better to rethink and to double down on that, because it sounds like we have the technology, we have the capabilities, probably easy to leverage that. Any additional questions on our analysis and our presentation?
This is Don. I'm going to just...
Go ahead, Don. We unmuted you again, Don. Sorry, the system keeps muting.
Very cool. Hi, Don again. Real quick on the telemedicine, I think everybody's enamored with it and happy with it, and it was perfect for COVID. But just kind of in the real world of seeing patients every day, and you know how Medicare wants to do these kind of things, there's a huge difference between you are talking to a random telemedicine provider and your own particular provider of your choice. So I just want to kind of put that out there to everybody, because I think telemedicine is only going to be so popular because a lot of people, when given the opportunity now that, we're not as socially distanced for medicine anyway and appointments, that it has tapered off because people can and they do want to see their provider in person. So I just am putting it out there as something that I know that a lot of us that don't utilize a lot of health care, to us, it's a great suggestion, but to a patient that has chronic illness and somebody who we want to be engaged in the process, telemedicine from a based doctor or a clinic-based physician or practitioner that they don't necessarily choose is never going to be 100%. So I just wanted to kind of put that out there.
Well, I think to complement your comment, a lot of, well, I know all the marathon doctors are, but a lot of personal private physicians are using telehealth now under COVID and everything now. So you can still see your own provider through an electronic appointment, whether it be on the telephone or a FaceTime kind of a situation or something like that. So I think people are getting more and more comfortable with it all the time with their own personal physicians, which is a good thing.
Part of the training we did for open enrollment this year was to encourage people to go and set up a relationship with one of our marathon health providers and do that in person and see them at least once a year for an annual physical or something along those lines. Then if they need to see somebody for an acute visit or that, they've already established the relationship, right, and they can go back in between, or they can go in person. But we would encourage, and I did encourage everybody as part of my training to make sure people establish that relationship if they can first, and then consider the telemed as an enhancement. My thought is we're going to continue to do that type of messaging.
Okay. Anything else, Jim?
Nothing here, unless you have other questions.
Anybody have any questions for him? No? All right, thank you
Okay,
very
thank
much
you.
for your information.
Thanks for the
Appreciate it.
opportunity.
All right, on the agenda, we're going to skip back to number 4 and have Jonathan come give us the all of that on section 4. The trend analysis, we'll call it.
Okay, perfect. Thank you. And as you can see on number 4, we're going to talk about historical medical trends, the fund balance, and then we're sharing our quarterly. We have a quarterly data report that we share, which we use Truven, which is an IBM Watson dashboard, which I'll share with you. One of the requests that we had from the group was to talk about the total expenses over 17, 18, 19, and 20. And what you have in front of you at this point in time is a chart, which I'll go through. As far as the total expenses, it includes the medical spend, the pharmacy spend, the clinical spend, your ACA fees, and your administrative costs. And you can see on the top where we have total expense in 17, it was around $69 million. Average members was around 11,648. And then on a spend perspective, it was per member per year is about $5,962. In 2018, it actually decreased. It was a negative 2.8% trend, which is a good thing. And then, as we had mentioned earlier, we've seen the trend go up. In 19, it went up about 6.6%. And then in 20, based on, the numbers and the actuaries worked on this using the same numbers for the fourth quarter, we're projecting right around 5.6%. And this, obviously, these expenses would continue to go up. We had this conversation earlier in the year and last year where we knew that there was no increase in contribution or premium, so we knew we were going into kind of a different direction, and you made some adjustments. And so I want to make sure we recognize where you've been. I think it's important to know where you've been to understand where you're going. This is the next page is basically our executive summary. Again, this is a report that Aon produces. We basically take a look at all of the data and the information. I think it's critical to take a look at this. As you can see, from an executive summary standpoint, the plan has been running about 110% for January to September. 110.1 to be exact. And then the prior 9 months, comparing, that 9 months, the current 9 months to the prior 9 months, it was 110% as well. So when you look at that first column, that'll actually share the total 2019 loss ratio of about 108.4%. So as we talk about the numbers, and these are numbers that are with COVID built in. So I think, it's important to understand there has been some decrease in utilization. However, when we go through these numbers, I'll show you what has been occurring on large claims. So as you look at some of the top bullet points, I already talked about the loss ratio. The per employee per month trend net claims is only about 300 basis points higher than the prior. Your total pharmacy spend is about 22.7 of the overall spend of the plan. And then the second to last bullet here is pretty critical. There's 7 large claimants over the individual stop loss this year, which is over $4 million. You still have the 3 quarters to go, or 3 months to go. But if you look and take a snapshot of last year, there were only 2 claimants that were above $425,000. So I want you to really keep that in the back of your mind, because when I go through some additional numbers, you're going to see some trends increase in inpatient costs, average length of stay, et cetera, because these large claims are in there, and there's a large spend in that space. I'll go over this at a kind of a high level, but really the 1 and 2 is your enrollment and your premium difference. So once you make, we take a look at all the people that enroll and what they pay, what the employer, the district pays. There's really no difference year over year. Now, when I talk about projections, which will be in a couple pages, we did build that in. So that's going to be a little bit different based on some of the changes. And this is just more of comparing year over year. Total claims, you can see under the number 3, total gross claims. This includes the medical and RX spend. That's running right now. And this, as I mentioned, was pulled through September, so January to September. We did have June, so we did update this just before the meeting. June was running more like 5.5, 5.6. This came down a little bit, but again, I think you've got the COVID
Amy said
impacts.
I could go ahead and
Hold on.
talk. I just want to make a statement. This is a little bit behind, but I sat back and thought about this. $75 million is a lot of money. I think I remember on this committee where we were at $45 million. So salary and benefits are the biggest thing in any, large company, but forget how many zeros are on here. And I just want everybody to kind of like take a deep breath and think about that for a second, especially, I'll remind Tina and then, the school board members, but that is a huge number. So I know we're looking at it just in terms of increase or decrease or whatever, but $75 million, we are getting up there to $100 million. So, every penny counts in what we're spending on healthcare.
That's a great point, Don. So as you look under number 3, you'll see stop loss reimbursement. Last year at this time, there wasn't any reimbursement. This year, you've been reimbursed about $730,000. I think rebates, RX rebates, as you look at this, this is after the RFP that we did. We're seeing higher rebates come in. If you look at this year, 2020, you've got 2.8, 2.9 million in, where last year there was about 2 million. So we're seeing some savings or dollars come in higher than they did last year. And then under your net claims under a medical and RX, again, it's just a slight increase in that space. Under your total fees, we did see a reduction of about 8.5%. If you recall, during that RFP that we did, there was a savings of a 3-month holiday, so that is included in this year. So again, nice savings in that from prior years. And under the total cost, as we look at the spend, it's just a little bit under what it was prior from a percentage change. I've already talked about the loss ratios, and then under employee contribution, employer contribution, pretty consistent over the years, 25, about a 25, 26% split. which has been consistent. What will be interesting is to see where open enrollment falls this year relative to where people choose a gold or silver plan, to see where the premium ends up. And I think that will be, it'll be interesting to see the final numbers and where we end up projecting.
Can I
Any
ask-
questions on
yes,
that page?
yeah, I have a
Yes,
question.
Anthony?
So we have a declining number of employees. This is showing 40 less than last year, and I imagine it might be even less than that in future months. How is that impacting the plan? Is that beneficial? Is there some sort of sweet spot? I know the premium contributions depend, on individuals, but the board did a flat increase. So is it a wash? Is it helpful? Is it you
Yeah,
guys
I mean,
like
it really
crunching
depends on
those
the risk
numbers,
factors
so-
that come on the plan and the risk factors that come off the plan. So we'd really have to take a look at the folks that actually leave and what the loss ratio is, and then we'll do more predictive modeling on the folks that come on board. There's no specific yes or no. It's going to be better. I will say though, Anthony, as we look at these numbers, we do try to do a per member per month or per employee per month trend to even all of that out on a monthly basis. So it's a better scorecard to understand trends where they're moving.
So are you just picking your brain where you're going with that? Are you thinking that because we might have had this year a larger percentage, I don't know the numbers right now, that were older, that went ahead and retired or had health issues and were because of COVID may have resigned or gone on leave of absence, that we might have fewer people with bigger health issues on the plan right now? I mean,
it's that would be one aspect, or just the board contributed a flat amount, a pretty large flat amount. Will that will that be beneficial because it's being going to fewer people, so to speak?
Are you talking about the 2.5 infusion and then hopefully the other 2.5 before the end of December?
Yes.
Yeah. And I think what Jonathan is saying is it really depends. If those people who've come off, the 40 fewer and people on the plan come off, were heavy users, yes, it would be beneficial. But if they're a non-user, no, I'm sorry. If they're a heavy user, it would save us money. But I don't know if that would be a material change because we're talking 40 people.
Yeah. Well, I mean, if it's 100, at what point does that become significant, if at all?
Are you talking about the loss of premiums from those people becoming significant, or the loss of claims?
All of it.
Both of it?
All of it. I mean, just because I could see this, I don't know, could be 100 employees. I know we're down 200 teachers at least, so.
Yeah, I would say materially from an underwriting perspective, anytime there's more like a 10% change in demographics, meaning, plus or minus 10%, then that's really the time to take a look at, what the risk factors look like. When I go through the Truven data here, I can definitely show the Truven, some of the target baselines that we look at for risk, and we could look at that number to try to evaluate what type of risk is coming on the plan and what type of risk is coming off the plan. So if you can save that, I'll kind of talk through that through the risk number, if that's okay. Okay. Any other questions? No? Okay, great. Okay, so here's some numbers again, actual versus expected claims. We went back to 2010. The blue line, as you can see, is really the Aon trend numbers. And so what the Aon actuaries do is they work with all the, we call them BUCAs, it's the Blue Cross, United, Cigna, Aetna, those are the health plan carriers, and we ask them from a national basis, regional basis, what their trends are, and then we take an average of those trends and come up with a particular number. So when you look at the bottom, you'll see the Aon trend. What we're trending, and Anthony, this goes back to trying to level that out on a per employee per month basis as far as what people are spending from a claims standpoint. We started in 2010 at the 352.64, and then the gold line is the Brevard Public Schools claims, and we included the medical, the pharmacy, the clinical components in those numbers. and then we took your actual numbers and then trended it out compared to ours. And I think the point is, on this line, what I would take away is, look, from a national trend perspective, you've consistently been, knock on wood, below the trend since 2000, or equal to the trend or below since 2013. So you're obviously doing some things correctly from an engagement standpoint, claim spend standpoint, compared to the national trend. And again, this national trend is there's no benefit change, there's no higher deductibles, there's no co-insurance changes, et cetera. And that's been pretty consistent with the school district at this point in time. At the end of the day in 2019, and we'll put 2020 in here when we complete it, but you're at the 489.21 on a per employee per month. And if you would have just kept steady with the trend on the national trend, it would have been that 556.34. Okay.
I think Ms. Butterfield has a comment. She's
Okay.
Asking to speak.
Sure. Oh, I have to unmute her.
Yeah, unmute her.
Now you're really asking me to.
Okay, Amy told me I can go ahead and
I can
put
hear.
my 2 cents in on this one. Anthony's question's actually brilliant because you can get to a point where we're, to be honest, I'm reconsidering my own personal health insurance even at my age, because it's getting to the point where it's the second biggest cost in my particular business, and I can either keep my employees or do something else. So, and be on the cross your fingers plan. But I think it's very important because it's something that maybe down the road we can do a survey. And for the people that aren't taking the health insurance, why that is. Are they just young and healthy and don't think they need it? Young and healthy people on the plan, but I think any decrease in the people on the plan is a red flag for something that we need to be watching.
Yeah, I would agree. Like I said, if it's a statistical significant number, we definitely need to make sure we continue to evaluate the risk that's involved. Okay. All right, I'm going to move on to 11208. This is the fund balance. Some of you, you've seen this before, but we just want to make sure we kind of go through the numbers. And I want to make sure you understand that with our actuaries, they basically, are using trend as of March. They think the COVID numbers, sometimes we don't want to under-predict what's going to happen with COVID. If we end up under-predicting the number, it can surge again in the fourth quarter, first quarter, second quarter of next year. And that's a real unknown piece. I'd also say, and I'm sure, a lot of folks here, this is going to include 18 months of trend. Because this is predicting things way out into December of 2021. So a lot of trend is built into this. And then with the assumptions that we have on this page, it includes your infusions that we talked about, Anthony, from a timing perspective. It includes your modifications and your changes in your plan design. It includes the gold versus silver. It also includes the migration numbers that were used in this particular formula. So those are all the things that have been changing. So all good, but I think we still just need to make sure we just want to kind of level set where the numbers were. So if you look on June 30th, 2020, the fund balance, the 12 million, say 0.6 million, 12.6 million, sorry. Your filings were already, they were sent to the state, the 11208. It was approved by the state for June. Everything is good to go there. And then when we look at the rest of the year, we're projecting about 9.6 million. This says 9,595,000, but about 9.6 million is what we're projecting the balance to be, or the loss, I'm sorry, for 2020. The balance at the end of this year, 12/31, we're expecting to be 2.994 million. And then you obviously, as we talked about, you need about $12 million in order to hit that 60-day 11208 filing criteria. So it's going to be short what we're projecting by the end of the year, about $9 million. Now, the timing of this, now the next components when I go through this, a lot of this is timing because you have that double month in June. So ABK, your actuary, Amanda Brooke Cross, took that into consideration as well. If you look at January, where we start with the fund is just under $3 million. Then the projected loss or gain in this particular perspective, it's $5,457,000. Again, as I mentioned earlier, you made changes to the plan, you made contribution changes to the plan. There's a migration pattern that's incorporated into this particular number. So we're expecting a gain based on that first 6 months. Then that puts your number as far as the fund balance at $8.451 million. And you need about $12,371,000. So it's just under $4 million short by the time the filing should come. A lot can happen between now and 6/30, as you know. As we said, if your migration patterns come back a little bit different with the gold and silver plan, that can impact it. COVID can impact it. But again, you have the 7 large claims that we mentioned earlier that are running at $4 million, and you still have three months to go. So we could see some, additional high-cost claims, and we might not. But as we look at these numbers, we'll have a better feel. So for July, as I'd mentioned earlier, you've got about $8,451,000 would be the balance. As we said, short about $4 million. And then the second half of the year, and again, this goes on the timing component that we talked about earlier, it's going to be a loss of about $6,358,000. So the balance at the end of December 31st will run at about $2 million, which in the end means it could be short about $10.278 million. Trend, as I mentioned earlier, is built in, so you've got, the trend that we use, that Amanda Brooke Cross used, is at the bottom at 6.1 on medical and 6.7 on the pharmacy piece. And again, these modifications, we use that consistent trend through March until we see where COVID lands.
I have a couple questions.
Absolutely.
So why don't you use the BPS trend in these projections? Why are you using the national trend?
Yeah, great question. So the actuaries, in order to be, they're certified in what they do this all the time with 11208. And the state generally, wants them to use national trends. So I think we went through this maybe 6 months ago where we showed where your trends were, and they are lower. However, you've had some bad years where it was like 8 or 12%, and then you've had some good years. So the best predictor, is to try to maintain that consistent trend number. And from a financial solvency standpoint, that's where the actuaries, go and use that number.
Would it be possible to see this using our trend rather than the national trend? I mean, I understand they might have to do it for state statute, but just for our purposes?
So the answer to the question would be yes. The challenge, I think, that we'd have to put a lot of assumptions on there and a lot of warning Will Robinson type of options on there, is the fact that COVID is really impacting trend. So it's running, a lot of plans are running lower than normal. So we expect that to come back, and that's not going to come back probably just month by month. It could come back at a big rate, and then you could be in a world of hurt at that point in time. So going back to answer your question, yes. I just want to make sure that you're aware of the potential impact of that, and be aware of it. Does that make sense?
Yeah. I mean, when I'm dealing with a teacher who's in trouble, I give them the worst case scenario, of course, because I'm obligated to do so. But I also give them, the best case scenario as well. So I think it'd be fair and appropriate to see that scenario.
Sure. Be happy to do that.
Okay. And then one other thing. I'm sorry, Mark.
I also agree. I mean, this needs to be updated, and it will be once open enrollment is over. Because remember, part of Amanda Brooks' assumption was 60% of our employees going to the silver plan versus 40 going to the gold. Well, it's running the opposite. It's 2 to 1 gold at this point. So,
And that
you
is
know.
the result of a lot of bad information out there.
Well, I don't want to say we told you so, but I
There's
gotta.
a lot of bad information.
I think
I
there
don't
are
want to
some
say
concern.
that, but I'm
Can
going
you
to say it.
elaborate on
I will be happy to elaborate on that. One of the most recent ones I've heard is the gold plan is for anybody who lives in Florida, silver plan's for people who live in Titusville. I've heard that gold plan is for people who travel out of state. Silver plan is only if you have a Brevard County doctor, and if you have a doctor anywhere else in the world, you have to go gold. My doctor didn't pop up on the very first page of that spreadsheet, so they're not in the silver plan. When I've helped about 5 people, yeah, they are in silver. There's no reason for you to pay for gold. There's so much bad information, and we're going to have so many unhappy people when they realize they could have taken the lesser plan and still gotten the same coverage with the same doctors.
Well,
It's bad.
We certainly really wanted people to meet with an AFLAC counselor, and we've advertised the heck out of that. We created the spreadsheets that have the voiceover, and we've done all sorts of training. I'm hoping that we can, I know that Anthony had talked to us about meeting and possibly helping educate, so I think we are going to do that, hopefully in the next couple weeks, and we can start that process. I also believe it's the first year whenever you start a plan, and generally I think there is going to be some fear of going to something new before they've checked to see what their friend's experience was like. So I think that could be a lot of that.
And I'll tell you, never one to do things really early. I was actually doing mine today. I had to stop in the middle to come to the meeting, but I had to call the one doctor that would have been the difference maker for me personally. Choosing between gold and silver was my kid's pediatrician because he's amazing. We've had him for years. And when I looked on the spreadsheet, his name was not listed, but there were multiple other doctors from their practice, and he's not a health first doctor. So I actually had to do the work of calling and saying, hey, this doctor, and this doctor in your office is on the silver plan. They were already aware. They said, we have got it right in front of me. We've done some research. I've got silver plan. We said is okay. So I actually had to call and do that research because you can't see it on the Cigna website because
It's not there yet.
right, it's not there yet. So, but the spreadsheet, and that was confusion. They're like, I have this gold plan in front of me. We don't know anything about that. And I made sure to say, well, the gold plan is actually what we have now. So they said, no, silver's good. So sometimes even the doctor's offices are confused.
I think there's a lot of confusion at the employee level. They don't realize that just because a doctor is affiliated with Health First does not mean they're not necessarily also affiliated with Steward, and that they're not also just private and will take the Cigna Silver on their own, separate from their Health First affiliation. And a lot of people don't understand that. They think that if my doctor has that Health First banner on their marquee, that I have to choose silver. Or I have to choose gold. I can't choose silver. There's a lot of confusion like that, and they, teachers right now aren't having time to dig through spreadsheets to look for their doctor. They're overwhelmed. So I think we might need to consider extending open enrollment to allow more time for education or some kind of face-to-face education through a faculty meeting format or something like that to avoid complications later.
I think doing that this year, we really couldn't in order to get a 1-1 start. So we might have to do that next year. We can expand it to a longer period and give more explanation to folks. But we are running up on a closed end of the year, and so we've got to get through this Friday. That's really the last date we can do it. Yes.
I called one of my doctors because he was formerly a Health First, in the Gateway building and has moved out of his own practice. And I'm waiting for a call back, but my question to him or to his office, will you go over to have the Steward Hospital, practice there in addition to the Health First, because this is an option for employees all over the school district. And that was the thing they asked me. Is this just because I'm a retiree? And I explained I'm a retiree that's not yet eligible for Medicare. So is this just for just retirees? I said, no, this is
Everybody.
all over the county, and it is all of our BPS employees. So that says to me, is Cigna doing anything to get those doctors that are the independent ones, the ones that aren't in that Health First building and one of the Health First quote unquote doctors, are they doing anything to let those doctors know this is happening and they may be losing a bunch of patients if in fact the people switch to that and they don't know that it's happening? You know, what has Cigna done? They presented this to this committee. They got us to go for it. They got the board to say, yeah, this is what we're going to do. But did they do anything on the back end to try to get those doctors that aren't Health First, you know, own, to get those people and make them understand this was going to be coming down the pike?
Well, I can say one good thing about that very, very long spreadsheet we were given about everybody who's on the silver plan. If you just do the simple little Control F and put in the name, every coworker of mine that I've helped coach through this process, every doctor they've asked about has popped up on silver. I have not had one person yet not able to find one of their physicians.
But you're in the north part of the county.
Right. No, but we're talking doctors in Melbourne. 90% of the doctors are in Melbourne. They're Health First affiliated physicians. But they also, because of their private status, are acceptable under the silver plan.
Yeah, Melbourne Regional.
But people don't understand that.
Right.
They don't understand that. And so they think, oh, my doctor's in Melbourne, must be Health First because that's the marquee in the building that they lease in. And they think, oh, I've got to buy gold. No, no, you don't.
Well,
That's the problem.
As a retiree,
Yeah.
on our plan,
Yeah.
it's $60, $70 more a month.
It's a lot of
for
money.
me, because I'm also paying the board portion as well as the employee portion. So, like I said, it may not be as big a hit on the ones, you know, that are current employees, but when you get to the side of their spouse and their family coverage, you know, those costs go up for them too.
It's a
So
lot of
Sure.
money.
it is gonna be a big hit if they, you know, could go to silver but aren't understanding.
Yeah.
And their doctor didn't get a heads up to know this is happening.
And I think we need to monitor social media very carefully because there is a lot of false information out there on social media from employee to employee. People ranting and posting things that just simply aren't true. So I don't know who at the district monitors that, but it needs
So-
to be monitored.
Just if I could, Mark, I think one thing that, and you know, we've shared it with you, the biggest question we have is about out-of-state situations, out-of-county situations. You know, we still have several more days or a couple more days left of open enrollment. If you guys could put out something clarifying how out-of-state works with the gold versus the silver, that would be helpful. I mean, there's still time, so.
Yeah, I don't have a problem with that at all. I was hoping more people would watch some of the PowerPoint slides that we had, but obviously I'm
You know the
hearing
response
that
you're going to get to that is in my excessive spare time as a teacher teaching fully
Yeah.
online and fully in person. And yeah, no.
I tried to view the afternoon session that you had with the benefits contacts, and it keeps telling me I don't have access.
Really?
So I don't know. It could be user error, but
Okay. Yeah, because I think that should pop up right from our link, but I'll go back and check that. Thanks.
Okay.
And we're taking clear off topic, so go
I
ahead.
know. So Anthony, just to come back to your question a while back, is it okay if we wait till we get the final enrollment numbers so we can have a better number and then come back January, February with that information?
Yeah, that'd be better.
Okay, thank you. Okay, the next one is, now I definitely need to put my glasses on for this, but part of the program, this is what we call the IBM Watson Truven Dashboard. So what this is it represents about 27 million members in America, about 400 different clients that we have at Aon, where we have all their data integrated into a data warehouse. and we have reports that we basically, are able to produce. And so very busy slide, more of a GE slide, back in the 90s where they put all these different boxes in there on one page. So it has a lot of information on there. But I'll walk through this, and I mean, based on time, I'll try to hit the high levels if that's okay. But if you want me to slow down, I'll be happy to slow down as well. But really, we've got on this particular page, you can see there's 7 different little areas of data and information. So under number 1 is your net pay on trend. And net pay includes your deductibles, your co-insurance, your co-pays, et cetera, as far as what's actually paid out. And you can see up on the top, we're looking at a period time from April of 2018 to March of 2019. So we're comparing 12-month incurred claims versus a 12-month of current claims from April 2019 to March of 2020, with it's paid through June 20th, or June 2020, sorry. But this is critical because it's that time period that we're looking at. And so we look at different time periods, and as you know, if you look at different time periods, you will come up with different trends, and you'll come up with different numbers. But in this particular snapshot, we're seeing a net pay. If you go down, you'll see the blue line obviously represents the total as far as the net pay and spend, and then at the under the by rolling years, you'll actually see the net pay from a medical claims and pharmacy claims standpoint, and you'll see where the previous spend during this time period was about $61 million, and then the current period, again incurred April 2019 to March 2020, is about $65 million, right around a 6% trend. It will break it down from a PM standpoint, and again, PM is per member per month. As far as what that looks like from an inpatient standpoint, you'll see there's an 11% increase there. From an outpatient standpoint, you've got about a 7% increase. And from a pharmacy spend perspective, compared year over year, it's about 1%. And what we're seeing on benchmark, which is the 27 million members there, it's running about 5%. Under number 2, which is to the right with the graphs there,
But
you'll see.
Jonathan, I want to, but the benchmark is still higher than where we are, right?
Correct. Yep, absolutely. Benchmark is from a PM standpoint is correct. It's higher. So all these these numbers run well, and I'll get to that risk factor. Your risk factor is.
In other words, our costs are increasing, but it's still lower than the benchmark of other employers in this comparison.
Correct. That's correct. In this time period.
Right.
Yep. So drivers of the net pay on a per member per month trend. This shows where there hasn't been much change in the cost share, which is where the member may come out of pocket. The inpatient price points went up about $18 on a per member per month basis. And as I mentioned before, you got some high cost claims. A lot of times those high cost claims, you'll see these inpatient costs go up. Now what's interesting in this is where you see IP use. That's actually your inpatient utilization. So that actually saved you $6 on a PM basis because not many people are going into the hospital. So even though you have people going in, they're going in longer, they're going in for more expensive surgeries, et cetera. Those costs are going up, but the utilization has come down. And you've seen movement to people are going to outpatient, which is not a bad thing. It is increased. However, it's, when you look at your outpatient costs versus your inpatient costs, big difference, saving money. People going there is better than going inpatient if they get the quality of care they need on an outpatient basis.
So I want to make sure I understand this.
Mm-hmm.
The IP price is just that's what the market is paying in price.
Right.
But our IP use is our actual utilization is $6 less than what the market is paying. Is that what I'm understanding?
No,
there?
it's more of a utilization number, meaning you're using it less, $6 less.
Oh, okay. All right.
It's more of a utilization number. And the same piece will go for your pharmacy pricing. You'll see where we're starting to see pharmacy pricing go up. This again has a lot to do with specialty drugs, I think your specialty drug spend is 52% of your total spend, but the RX use or utilization has come down. If you look on number 3, where you have the high-cost claims, again, in this particular dashboard, $50,000 is considered high-cost claims. And you'll see the number of patients from a previous standpoint to current. You've seen an increase of about 2% as far as the number of patients of 50,000 plus. Patients per thousand has gone up about 3%, but the payments, as we mentioned earlier, have gone up about 10%. And then when you compare your payments per patient, those costs have gone up about 7%. And then what they'll be able to do is basically look at your net pay on a per member per month for non-high-cost claimants. You know, slight increase, you're seeing about 4% usage in that, or trend in that space. And then the net pay from a high-cost claimant standpoint is about 10%. So as I move back down to the left under 4, where it says medical plan eligibility, Anthony, this kind of goes back a little bit, I think, to your question on, okay, if people come on and off the plan, what's that look like? This will give us just the number as far as what the trend is as far as people coming on or coming off. However, and then it gives us the average number, family size, and then we can take a look at the employee age. If that remains pretty consistent, or if that changes, then you know, that'll impact the risk score, which is actually below that number 6, which I want to stick with the going 4 or 5 and stay in order. So I want to draw it in between the lines. But those are the numbers there. Did somebody have a question on number 4, or you good? Okay. All right, so under 5 is really price and use. So this, again, are the trends that you can see, and it's got the percentage above the line and below the line. Below the line being, you know, the use or utilization. Flat on the line is right at, you know, it's the same. And it basically just kind of paints a little bit of picture, a different picture of where the trends are from a cost perspective and from, you know, length of stay, et cetera. And I'll go through below, on number 5, below the graph, you can actually see the numbers. And when we compare benchmark, that's the IBM Watson benchmark of the 27 million folks, where the net pay per admit is you know, 31,000 versus 24,000. Admits per 1,000 are actually lower. So as we had that conversation earlier about the clinics, you know, these are potential measurements, I think, on your clinic model, where as your risk factors are higher, your actual admits for inpatient, you know, can be lower. Challenge on the one below are the days length of stay. Again, as I talked about, the high cost claims are pretty significant. Those are making people stay in the hospital longer. In this particular time period, from April to March of 19 compared to April, March of 2020, you had a higher average length of stay. A couple other points on this one I would say is, you know, the emergency room visits, again, are lower than benchmark. That's always a good thing. Keeping emergency visits low. You have the clinic, you have virtual phone calls to the Cigna program as well as to the clinic model. Those are great access points for people. Urgent care is a great access point for people to stay out of the hospital. And then again, on your prescription drugs, you are, you know, you're better than the benchmark on a net pay per day's supply, as well as the supplies allowed per member per year. All positive things out of those. You've got 5 that are positive, 3 that are negative from a trend standpoint. And as I move from 5 to risk score number 6, and Anthony, this is where I think we could probably use some different metrics to understand the impact of new folks coming in and falling off, is really around the age and the sex, as well as the risk scores. So risk score is basically 100 being the baseline for a pretty young, healthy group. 100 is the baseline of that. And the previous score for the district was 120, and then current, you're seeing at 125. So the risk score indicators for, claims and complicated particular members has gone up. And I think continues to be one of those areas that you could use as a potential benchmark for the clinic model. Again, when you're looking at evaluation and some options there. And then cost share at the end of the day, cost share, that just says how much comes out of the pocket of a district member. That's been consistent from a medical and pharmacy and total standpoint, anywhere between the 14-15%. And then, of course, the last piece are the key findings, and we've talked about this as far as the trend at 7%. High-cost claims are about 43%. Net payments in that evaluation, and that's trending about 9%. Outpatient, as we mentioned earlier, was the higher trend, and you're favorable in 5 out of the 4 metrics. Any questions before I go to the last page on the IBM Watson Truven data? A lot of information. I know. I appreciate your patience on this, but I do get excited when I see this because it gives us kind of some guidance and opportunities in there.
Yeah, we had a prior trend that indicated higher utilization of UC, urgent care centers. So on the one hand, we see a lower utilization of emergency room, which I agree is better. However, have we seen also a lower utilization of urgent care centers, so it would be higher PCP and then higher clinic?
Yeah, the clinic. So the clinic model, we just have the marathon data. That's, we've got to be able to figure out how to incorporate that into these particular reports.
Yeah, I'm just asking though, we had a significantly higher utilization of urgent care centers in a prior report. We're trending down on the emergency department piece. Did we also trend down on the urgent care center piece so that we could pick up more savings?
I think what he's talking about is our preferred health center numbers.
Yeah.
And the urgent care, because we have both of them.
Right.
I think Cigna is going to have that data here, so we can dig into that number when Cigna goes through their numbers.
Does Truven not track that at all?
We would have to pull a special report for that.
Maybe that's worth looking at next time we run the data.
Okay.
Is to pull PHCs and urgent care out of that. That's good to look at, as well as Marathon, because they're taking people from that as well.
Okay. Last page for us is the top medical conditions. This is number 8, and basically at a high level, when you look at these numbers, this is where a lot of your spend is occurring. And look, number 1, preventive, high encounters. This is preventive care spend, so this is a good thing, right? So most, if not all, the reports that I look at, this is usually number 1, which is great because it means you're using the plan, you're accessing care, you're accessing wellness exams, etc. And so that's a good thing. Your 2 top, when you look at number 2 and number 4, the total of those is about 4 million, 3.8 million newborns and pregnancy with delivery. So, real good opportunity in that space to make sure and catch people in early pregnancy programs through the Cigna program. I would say the other piece in here is really the cancer under number 3 and number 9. Good areas, to continue to focus on trying to address those at a preventive stage, because the earlier you catch that in a 1, 2, or 3 stage, the better off as far as an outcome. You don't have those high cost claims.
Jonathan, is there any way on those we could get the benchmark data? Because it'd be interesting to find out how we're doing in those areas against the other other entities that we're compared against.
Yes, I can pull that as well. Okay. And so for benchmarking, as Mark just mentioned, just making notes, appreciate it. The screenings, you can see, again, this is a point in time. This is April to March, and this, sometimes you can have people pick up their screening later in the year. But you can see as far as how this compares on benchmarking is in the gray. And your current versus cholesterol annual screenings is at 66. The prior year it was 69. You're beating all benchmarks on these screening programs, which is something to be very, very proud of. If you look at number 10, the top issue, really one of the top components is hypertension. That's way above benchmark. Your diabetes. Again, a lot of these areas is where you really need to focus the clinic and that proactive approach. We're seeing really good success on some organizations that are focused on a virtual solution for diabetes. You've got Livongo, you've got Virta Health, you've got some other programs that are out there that are making impacts. And then on number 11, you'll see the prescription drug, the metrics here where the top spend is under the Crohn's, MS, lupus, transplant, psoriasis. That's the big spend in the specialty space. And the next bucket really talks about your benchmarking relative to the scripts percentage on a generic standpoint at 87. That's chosen, and then the efficiencies at 98, which is fantastic. And then the mail supply is about 9% out of total scripts. And then, of course, that's net pay on specialty, as we've talked about before, is about 52% of the pharmacy spend. And you'll see, we've already talked about all the key findings, on the right-hand side. These are all the areas that, we did the analysis last time on specialty drugs. We continue to improve and use the clinics as much as possible to drive a lot of these chronic conditions to a better outcome. Okay? Any questions, comments? Good? Oh.
On your Truven for comparison, is there any way to provide more detail on the universe of employers, like type of employers, size of group, where we can see what we're being compared to?
As far as like public sector, Florida breakdown, I'll have to check to see if we can break it down from that standpoint. We do some benchmarking with a lot of our groups, Dominic, where we look at certain areas, but I can definitely see if this is another opportunity.
Okay, thank you.
Sure.
Yeah, that's because we are, we're pretty far off on some, like the hypertension, the diabetes were significantly higher than the benchmarks on those two areas. Interesting to me that we're lower on the depression.
Yeah.
That's last year's data.
Well, this is before, before you got, this is March, right?
Yeah, right. And
This was
osteoarthritis,
pre-COVID.
I guess, makes sense because we do have a younger, maybe, workforce than the non-education world, non-public sector. But it clearly shows in here we've got work to do on diabetes and hypertension. Because having a younger, that's the other way around. Like, okay, we don't have osteoarthritis as much because we have a younger population, but look, oh my gosh, we've got more hypertension and more diabetes in the general population. So,
Well, this is just identifying. It's not looking at compliance with care. So
We can
yeah,
pull the
I
compliance.
think that's really what we need to know.
And those numbers could be skewed because people are seeking health care for those issues, and that's why it's coming up more.
See, the one thing that's been nice, obviously this year we're kind of handicapped because of COVID-19, but because we require everybody to do a biometric as well as a health assessment, we identify a heck of a lot of people early, which helps, Cigna, RN health coaches to reach out as well as Marathon. We're a little bit handicapped this year, and I think that kind of shows in the screening rates that are here. Because if you look at last year to this year, you can see a decline on those screens, and I think that's a lot of that. But if we can get back to that, if we can get people to do those screenings in our biometrics, I think we'll get there. What really matters is how much are we actually catching those people and giving those drugs early before it becomes a major hospital issue. Because that's where we really need to make sure we're staying ahead of the game. So
Absolutely.
Mark, can you explain, at least in the past when we had biometrics, what exactly happens with these people who are identified, how you're saying whoever reaches out. So who is it that reaches out? How do they reach out?
It's both. The health assessment is great because both Marathon and Cigna get that data directly, as well as the biometric. The biometric is just a great snapshot. I don't think it's as good as an annual physical. I think an annual physical would be a better requirement, but I think getting everybody into an annual physical would be kind of difficult to do from year to year, although most people like to get their annual physicals. So the biometric is just a quick snapshot. If you have cholesterol, that hopefully their doctor is going to look at that and get them either with the drugs to reduce that cholesterol level. If they have high blood pressure, they'll bring them back hopefully and work with them to get that blood pressure down. If it's done in the Marathon clinic, which is what we really want them to do, that's how they're getting those patients directly saying, your blood pressure is at this level. We want you to come back. And so they will work with them to try and get them the drugs that they need if they've actually developed that hypertension. So that's how it's done with the clinics. The same information is given with Cigna. So Cigna will send letters out, or they'll call people to hopefully reach out. And then, so it's kind of a twofer. We get health first, or not health first, but Cigna, RN health coaches by telephone and letters, they'll call in and people can work directly with them, and as well as the Marathon Health Centers, because those are the ones who will talk to people face to face while they're there getting the biometric.
Is it an X amount of times they reach out? Is it how does that? We've been through this before, but it was a long time ago.
Yes, Cigna will reach out as, I don't know, I think people have complained in these meetings before because they call too many times or they send too many letters, right?
Well, they will keep trying until they talk to you and you tell them to stop.
Well, that's
Right,
good.
so they've lost
Yeah.
any interest the person has in participating just by pestering
Right.
them.
With Marathon, they, because they're talking to them at the time they're doing the biometric, it's a much more softer approach, but they're also there with a concerned face, which I think a lot of people are listening to, and they're coming back to those appointments. I was a little bit, I was kind of surprised where he said the participation was 17% earlier, because that's different than what I recall Marathon giving that number for chronic condition visits. But so I'm going to look into that. But I think they are getting a lot of those high chronic condition folks coming in. I thought the percentage was closer to 40 to 45% of them are going in for treatment. But they are coming back. So they'll meet them at the biometric. They are also doing calls now and other contacts. So because Marathon gets the feeds from Cigna on what people's health assessments are, if they're noticing that they have chronic conditions that are there, Cigna or Marathon will go through that information and they can identify people that have those issues, and they will also reach out to them by telephone. And so they're trying to do it in a gentler way to get them to come into the clinic.
So,
Well, and I can tell you just from experience that the phone calls coming from Marathon are more personal.
Are they?
Because they know you and they've seen you and they've encountered you and they've got your data. The phone calls coming from Cigna are more sales pitch toned. Like we're trying to sign you up for a program or a subscription or some kind of something like that. So I think people are going to be more receptive to Marathon's attempts to reach out because it is more familiar and more personal than they are to Cigna's.
So I'm just trying to get to a point with this in this committee that we're not just looking at these numbers, that we're doing something with them, because you can give us those numbers and okay, great. So I mean, for instance, just thinking out loud, brainstorming. So okay, most people did not do biometrics this year. They did them last year. So the ones who maybe they found an issue, cholesterol, whatever, that did not participate in some kind of wellness program or something like that, couldn't we reach out to those folks this year, and offer them an incentive to come back to the WellCare Center for another visit, for another discussion, $25 gift card, $50
Well,
gift
do we
card.
know that they didn't necessarily seek treatment privately. We just have data says they didn't go back to the clinic. That doesn't mean they didn't seek treatment.
Yeah, well, there's only one way to find out.
Well, we can look at any sort of thing to try and bring people back. I like I say, I was a little bit, I thought the numbers that we heard from RSM were lower than what I recall the contacts have been with Marathon. But I'm going to go back and validate that to make sure that's correct, because 17%
Well,
seems
I think
low.
I think his 17% is 17% of the entire insured population going back to the clinic. But of those 17% that went to the clinic, 40% of them that were diagnosed with a chronic illness or indicators of a potential chronic illness came back for a follow-up. So I think that's where the numbers might be different.
We do have some money that we can get through our contract with Cigna for wellness incentives, but I think that's probably not a bad idea, is to offer some of those things, to people. This year, because COVID has made it difficult to be face-to-face, we've held a lot of virtual classes, like virtual yoga and some different contests and that sort of stuff. Have we done it to the personal level? Not this year. We tried that a couple of years ago by giving everybody, I think it was either a $10 or a $20 gift card if they came to a visit at the WellCare centers. That wasn't enough incentive for them. So it's hard to balance how much do they need in order to get an incentive to go to the clinic.
I think the reality is a lot of people don't go to the doctor unless they're sick.
I think that's a lot of it.
Cut and dry.
Yeah, but we got to get past the point of throwing our hands up and saying there's nothing that
No,
can be done.
I agree. I agree with that.
It's going to be, this is going to be the story unless we do something different.
Yeah.
So are you suggesting that we take part of, maybe it wouldn't be the whole committee, but a subcommittee, maybe we split some of our slack time, certain months to say, okay, what are some ideas that we can use to motivate our employees to, if it's family members, we can't really do it, but most of the people on our plan are employees to participate in coaching, to whatever it is.
Instead of taking a stab in the dark, why don't we do an opinion poll? Why don't we just ask the employees, what would it take to get you to go to the clinic? I mean, that's a simple Google survey. It would take 5 minutes to create that and send it out.
Let's look at these really expensive, high prevalent, hypertension. What would you do? What activities would you like to see that would make a difference in hypertension, diabetes?
Yeah, I think a lot of, because people are still kind of unfamiliar, I think a lot of people, if your biometric comes back and says your cholesterol's out the roof, you're a ticking time bomb, they're going to go to their cardiologist. They're not going to come back to the clinic. And I think that's where maybe the numbers are skewed a little bit.
But the truth is, some of our people early on don't need to go straight to the cardiologist. I know Sheila's a proponent of this. They need to get on a nutrition plan. They need to get on an exercise plan and have the accountability of the coaching of the clinic.
Right, but that's where the mindset needs to change. That's exactly.
We don't always need a prescription first.
Yes.
I think and I depends on how you look at the biometric and the health assessment. But when I first started in this role, most of the calls I got were, why are you penalizing us? And I think I never looked at it as a penalty, because if you didn't, you'd have to pay your annual deductible would be higher. But that's the way they looked at it. But look at what those folks are doing. The compliance with doing a biometric and a health assessment is way off the charts. It's like 75% of our people are doing it because and I think a lot of it is that philosophy that they think they're penalized. So, where do you balance that between offering an incentive like you talked about, like $25, or penalizing people if they don't? Do you know what I mean? I'm assuming this year, because part of our enrollment this year was, if you don't, because it's an active enrollment, if you don't go in and choose the gold plan, the silver plan, or disenroll from benefits, and you're on a plan now, you're going to be charged the spousal surcharge. And it's amazing how many of the people who've currently enrolled are in a plan that includes a spouse. They are the ones who are worried that they're going to have that $250 a month surcharge. And those are the questions I'm getting from people saying, I just want to make sure I got the spousal surcharge taken care of.
So I just want to throw this out there. I'm not making this a suggestion, so don't have a heart attack, Anthony.
Don't come at me.
Yeah, I know. But, I was talking to our general counsel, who's new from Marion County in this last year, and he was sharing some of the things. I can't remember if it was in Marion County School District or when he worked in Seminole. I think it was when he worked for the county in Seminole, not the school district, but the county. They developed a plan of, it wasn't, they started out, they kind of eased their way into it. They had something like what we have, where you have to, the deductible is based on going and getting the biometric. And then over the course of a few years, it was, if you don't meet these standards, if your blood sugar is out the roof and your blood pressure doesn't change, then you're going to have a higher deductible. And so there was talk about some incentive to get in shape and to get to the doctor and to get that under control. It's like, if you're going to cost us more money, then you pay. Right, you're going to pay. So then they just kind of transformed the whole thing, and that sounds like punishment, but at the same time, we're trying to get our people. It's crazy. We're off the charts with these conditions. So, like I said, don't freak out. I'm
kind of freaking out. Yeah.
But that is saying this is from a fiscal perspective. This is costing us money, but from an employee perspective, our people are unhealthy, and what's going to get them there? And if it's, oh my gosh, it's going to cost me a whole bunch of money, I better get healthy. Some people, that's what it's going to take.
Well, I think that's the old adage, what's better, the carrot or the stick? And I think balancing that, so that it doesn't come off as the stick, more it's a carrot is something that we need to do, but I agree. I think we need to look at all of those things, so.
Well, I think the other part that Anthony was also getting to as well is that, okay, we've got these dashboards, we're seeing various things, we're hearing somebody's making a phone call. Would it also, though, not be appropriate, what's the plan to address diabetes, other than making a phone call? Because there's more to it than that, if you really want to do it correctly, if you really want to be effective with it. And diabetes, very honestly, is related to all of these other conditions on this page. So if you actually hit diabetes, you may actually and should actually reduce all these other conditions. So the question is, what program or approach, proposal would, and whether that is Cigna or somebody else, whether it's Marathon or a combination, what are they going to do to address this, to try to move these numbers in a positive direction, as opposed to, okay, we're reading it, it's there, we move on, and now what?
Yeah, well, and just to let you know about the diabetic program, when Marathon or Cigna identify somebody who's diabetic, they're told about the diabetic classes and they sign up. They will reach out and say, we have a diabetic class starting on this time. Would you be interested in attending? So Marathon is running those diabetic classes 4 to 6 times a year, and they're 6-week classes each, and their graduation rate is in the 80 to 90% range for all those who sign up. So they are approaching and helping us with that issue, but that's been in place for about 2 years now.
Are they similar to the diabetes education regimens like the hospitals offer and things like that? I know Parrish has a great diabetes education. Is it similar to that?
I've not compared it, so I'm not really sure what your program is to theirs. But I know that Marathons is a 6-week class. They teach them how to cook. They teach them how to handle their condition. They'll tell them what they should be doing every year on an annual basis for their foot exams and the other things that diabetics need to go through. So that's part of their plan. I'm not sure what yours is.
Well, it's not so much the program as it is, how do you actually get it to the people?
Okay.
And, I know that we go, and for instance, at Delaware North, we'll actually go and schedule programs to actually mirror the crazy shifts that are being worked at the Cape, to cut down on excuses for, well, it wasn't offered at a time that was convenient for me, or I've got kids and I've got all these other excuses that you typically see. So we try to take that away. And so that's why I'm looking at it. It's great that you have a program. How do you get it to the people so that they're taking advantage of it? And then in turn, we can see some positive trends in the right direction.
I think so far the classes are full every time they've offered. They are offering them at night, and they are offering them different locations throughout the district. So it's not just in the well care centers. They're offering them in schools, going to where people are located. So I know that the Marathon is doing that now, and we are seeing some success in that area. And I don't know.
Are they moving to a virtual environment on?
Pardon me?
Are they moving into a virtual environment?
I think
to
they're
provide the
doing that
information?
a bit. You know, I need to check and find out how they are doing that with,
I'm sure they would have to,
yeah.
under current conditions.
Or they're maintaining that 6-foot distance and wearing a mask. So
Masks.
I do know we're doing that, but maybe what I need to do is have Marathon come back and list all the programs that they're offering and what they're doing to do it, so you have an idea of where that is. We'll look at that in the future.
Jonathan, going to wrap up?
Yes.
Yes.
That's it.
Any other questions for Jonathan?
I think you got plenty of data. I don't
All
know
right.
if,
Right, we are moving on to our next section, the dependent eligibility verification audit. And is Bruns on the?
Bronze, can you hear us and start talking, please? Bronze, Dennison, please.
Don, yeah, I'm probably not caught up.
Can you hear me?
Yes,
Yes.
we can hear you, Bronze. I'm going to move your slides as we go through this. How's that?
That's slide 19 yet?
Yes, I'm on slide 19 right now. And tell me when you go to 20.
Right. Okay, excellent, thank you. Hello, everyone. I'm Bronze Dennison with Impact Interactive. As you Brevard Public Schools conducted a dependent eligibility audit from July 13th through September the 16th, and we basically audited every enrolled dependent that was on the plan. So that was 2,545 employees with 4,851 dependents. This is a two-step process, and the steps that the employees went through, the first step is they had to complete an online affidavit, answer questions about their family situations, and then step two, if they were still in an eligible relationship according to the Brevard Public Schools plan rule, had to submit documentation to back up those answers that they selected. So step two is submitting those documents. Overall, we had over 97% of employees that participated in the audit, which is a really good number. Mark, if we can move to the next slide, please.
Yes, we're on 20.
Can we go to the next slide?
He's
Yes.
there, Bronze. Go ahead.
Go ahead.
There we go. Sorry for the delay. All right, so this is step one. This is the affidavit results here. So if we look at the table in the middle, we actually had 7 dependents that were incomplete. Now, these 7 dependents did not respond to the multiple communications that were sent out. In a sense, the employees that these dependents go to, they didn't log on to the website, they didn't call the call center, they just didn't participate in the mandatory process. And then you can see that we had 20 that were actually ineligible by rule. And those are found because we have your plan rules programmed into the audit website. And the answers that they selected during that online process were deemed ineligible. So in a total, from the very first step, we had a total of 27 dependents that was deemed ineligible. And we have the breakdown of the ineligible, the rule breakers, if you will, in the bottom table here. So you can see we had 1 divorced spouse that was on the plan, and then we had for children that were biological over age 3 were a common law child of a common law spouse and then we had one that it was another child type, and they did not have guardianship, legal guardianship of that. We know that, BPS has a process in place to identify children as they turn 26, and I believe it's, if I'm correct, they can stay on till the end of the year.
End of the month.
Once that happens, but they were still identified within the audit, and this is kind of a snapshot of what happened there. So in the end, we had a total of the 20 that were ineligible by rule. So if we could, let's move to the next slide.
All right.
So the next slide is the document results, and so these are the documents that employees submitted for their dependents. So the first thing you see in the table here is that we had 4 spouses that were missing either a financial document or a tax return. So we likely received their marriage certificate, but we didn't get any follow-up documentation on that. And the importance of that is that the marriage certificate would show that they were married at some point, but the 2 joint financial documents, or if they just submit a 2019 tax return, we could connect them together currently with the financial statements in the last 60 days. For children, we had 2 biological children that were missing, 1 stepchild missing a birth certificate, and then we had a grandchild that was missing guardianship or custody paperwork. So they actually turned out, they said they did have a legal relationship. When they went to submit that document, they did not have the proper court-ordered legal guardianship or custody as they said that they did on the online affidavit. We had a total of 4 spouses along with 4 children that had incomplete documents. And then, as you can see, that lower line there, the spouses and children, we had 21 that did not send any documents at all. So they did complete an affidavit. However, the employee did not send any documents for these spouses and children. That typically happens because, sometimes employees want these dependents to be dropped. It's not during open enrollment. Maybe, it's a 24-year-old child and they have their own job and their own benefits, so they're saying, all right, I would like them to go ahead and be dropped. Maybe it's because they know that they have a ineligible dependent on the plan, and instead of being caught, so to speak, they just don't complete the process. So it's hard to say why some people do not complete the process, especially with the multiple communications. You see the ineligible there for spouses and children. There were no ineligible rule violations that were found on the document side, and that's pretty typical. We usually find all of the ineligible rule violations on the audit side, from what they select their answers to be to the questions there. If we could, So the overall results, we had 50 unique employees with 56 dependents that were deemed ineligible from the process. And looking at the table there in the middle, we look at the left-hand side, we had 7 non-compliant dependents on the affidavit, 29 on the document side, which gave us a total of 36. In the middle, we had the rule violations. We had 20 on the affidavit side. Documents, we had 0, so that drops us to 20. And then the totals on the right-hand side, we had 27 on the affidavit and 29 on the document, which brings us to our 56, which is a total of 0.1% of the dependents that were audited were deemed as not eligible for continuing coverage. The bottom table there, it basically just brings us back to 100%, but looking at this, we started 851 dependents that were in the audit and required to complete the process. 4,795 are good to go. They've been verified. The pool is clean, so to speak. And then we have our 56 that are not good to go. Add those two together, and it brings us back to the 4851. We can move to the next slide. If all 56 dependents were removed from the plan, we showed that you have an estimated annual cost to insure a dependent of around $4,000. So if you multiply out that 56 times the 4,000, that would give a first year savings of $224,000. Over 5 years, it would be $896,000. Again, it depends on if all 56 are going to be removed or not. But as you can see, it's a pretty good rate of return just by going through this whole process here. So I guess let me go through the next slide and we'll see if we can address questions. So the next slide, spouse coordination of benefits. So this is another savings that we see that could be beneficial. Looking at the spouses, anyone who had a spouse on the plan were employed, and whether or not they had benefits available. So looking at this, we had 208 that did not have a medical plan available. 66, the spouse did not qualify. Maybe they were part-time or contract work, something like that. But we did have 51 that were eligible for their own plan, but they were not enrolled in that plan. And then we had 12 that were actually enrolled in both and their own plan. 337 were spouses that were either unemployed, retired, or disabled. And we had 345 that were self-employed. So we know that those available. However, we are doing an additional outreach to the retired employees. If you had an employee that had a retired spouse, we're doing a reach out to see if we can gather a little bit more information about what kind of benefits those retired spouses have. And that's supposed to end the end of this week. We should have more information about that. So, but in the end, 80 spouses on the plan is needing a spousal surcharge, and this is due to the questions that we ask on the online affidavit, and then having them fill out a spouse health verification form if they selected that the spouse had no medical plan available to qualify. And what basically had to happen was they had to print this form. The spouse had to take it to their employer, have their supervisor or HR benefits personnel fill it out, sign it, and then send it back. And we were able to verify whether or not they actually had benefits available. And those forms have been returned to Brevard. So I think that's the last slide there. But I'm going to see if I can turn back YouTube and see if you have any questions, and hopefully I don't get any delays.
Yes, Anthony.
I have several questions. So are we sure that the folks whose dependents were identified are still employees of BPS?
Yes.
They're still employed and on the plan?
If they left the district during the audit time, they were taken out.
Okay.
So those were removed. Those are not part of the 56 that are identified. So okay. Those were taken out.
My next question is, was this factored into the fund balance projections?
No.
Okay. Should that not be factored in there going forward?
We just got this back, so okay. It'll be part of that, yeah.
I'm a little confused what I'm looking at with the spousal, 80 spouses on the plan were identified as needing the surcharge. And then I thought I just heard him saying something about,
Yeah, we're also doing, although I don't know if it's going to change anything when it comes to a surcharge or not, I've asked Bronze and his group to look and find out for employees who are retirees or have a retiree on the plan, are they able to get health insurance elsewhere, or are they getting Medicare? Because those are questions that I thought, after we looked at everything, that would be good to know, because maybe we can make some enhancements there. So he's going to be getting that back. It won't necessarily change the spousal surcharge at all.
but so potentially this could be 80 spouses that are required to pay $250 a month.
The 80 also include those that are currently paying the spousal surcharge. So, and I don't have the numbers in front of me, but I believe 29 of those are already paying it.
Okay.
And 11 folks have, insurance, their spouse has insurance, and we're verifying now that we are secondary to their insurance plan. If Cigna or us, we're secondary to their insurance plan, there is no spousal surcharge. So we're verifying that now. So the remaining balance of those are the ones that would be subject to a spousal surcharge. But what we're doing before we apply that spousal surcharge is we've sent out a couple of communications asking them or telling them that they've been set up, because of the dependent audit, they are subject right now to the surcharge. And we're asking them to verify that. And those folks are calling me directly. Okay. If they're telling me that there was something wrong with how they answered the question or anything along those lines, we're giving them a second chance by saying, get a letter from your employer that says your spouse cannot get health insurance through their plan, and if they are, then we're not going to apply the spousal surcharge.
So at some point, are we going to circle back to that? And
yes.
Because, I mean, that could be a substantial amount of revenue if
yes.
that's the case. And my last question was, as a paranoid employee that you said you were dealing with, I might be mistaken, but when I did my open enrollment, I don't remember seeing the spousal affidavit again.
It was there.
It was there.
It was there.
All right, I have to go back and look.
Both the spousal affidavit and the tobacco affidavit, they're all part of the same questionnaire.
It was in the end with the tobacco stuff, yeah.
Did you print, the key here is,
yeah.
when you finished your enrollment, did you print out your
of course.
your confirmation
Yeah.
statement? Okay.
It says it on there somewhere?
Well, as long as you have that, then you pretty much answered that question, because you can't move forward without it.
Okay. Then I did it. I could stop being paranoid. Okay.
Don't worry, those are a lot of the questions I get from people every day during open enrollment. I just want to make sure I got it.
So Mark,
my
I have
question, go ahead.
I'm sorry. Is
Go
that
ahead,
okay?
Sheila.
Sure. A point of clarification for those who have double coverage.
Mm-hmm.
So typically on, for group insurance, the secondary primary, that employee's program is primary. So I'm not sure why you're having to go out to confirm whether they're primary, secondary.
We're
the employee
verifying
probably
with-
isn't not going to know.
Let me say it this way. We are verifying with Cigna that we're not primary. So that's something we're checking to make sure we are secondary. Their insurance would be primary, we would be secondary.
In case they're not telling us
understand now.
Right.
the truth.
That makes
they're
sense.
Exactly. Because if we are not primary, then
Then we get surcharge.
if we are primary, then I think we need to be charging a spousal surcharge.
Absolutely.
So that's part of the steps we're doing right now.
So we did this for people who were currently, we're going into open enrollment, or we're in open enrollment right now.
Mm-hmm.
So are these people flagged so that as they're going through enrollment, they can't just go back and do it again?
We're going to be checking their names against everything after open enrollment, yes.
Okay, okay.
Yeah, we don't want anything to come back on that's not correcting the problem.
Right, for the spouses and
Yeah.
for the dependents.
What is nice, and I think this is a nice part of our Easy Benefit program, a lot of those dependent audits, the overage dependent audits, over the course of the audit, had picked this up, and we had already removed them. So, you know, even though that says 56, it was a lot less than that because they were automatically flagged, and we had already taken them out. So that's a good thing. And the communications with those employees was immense. I mean, they were contacted at least 17 times, you know, to submit their documentation, you know, and that included telephone calls from me and letters. I mean, it was immense.
Well, and I know, like, even for you know, for us it was Pam, but the contact person for your school or your department also came and said, hey, you haven't done it yet.
Yeah, we wanted to make sure this was pretty accurate. I mean, Bronze Dennison, who's with Impact Interactive, I think you're still on, Bronze. If you agree with this, tell me. If not, tell me now. But you thought our numbers looked really good in response compared to their other clients. Is that what you would say, Bronze?
It's got a delay.
Did I mute you?
No, hang on, he's still listening.
I think it's a delay going on.
Bronze, did you hear me?
This way.
It's a delay.
It's the delay, Mark.
That's a long delay.
Now you've muted him, I think.
Well.
While we're
Correct,
waiting for
yeah.
that.
You had a great response to this, and I think it was, you know, because of both of our initiatives, like you said, you know, over 17 different communications. And the other thing, the audit period was over for, I think, almost 9 weeks, 60 days or so. So there was a lot of time for them to be able to complete this. So I agree.
Yeah. So I feel pretty good that we were able to pick up a lot of this, and you know, it wasn't a tremendous. You know, that we had been told that they could save us. You know, some of the people who submitted bids said they could save us $1.5 million. There wasn't $1.5 million. So I feel pretty good about our staff catching these things as people age out or come off the plan. But it's always good every 5 years to do an audit, and so I think it's well worth the effort. And I think it is paying off because we are going to see some savings out of this. Obviously, you saw the numbers there.
Right. If there's nothing else, I think for sake of time, we need to move on to Brian McNeil's updates from Cigna.
Okay, Brian, you're going to have to start talking, and I'll move. Just tell me when you're out of sheet, and I will move the to the next slide. Brian, can you hear me?
Okay, hi everyone. Yes, I can. Good afternoon. Hi everyone.
Oh, by the way, just to let everyone know, he would be here, but he doesn't have COVID, but he was exposed to somebody with COVID, and so he's on a quarantine at this point.
Correct. Can everyone hear me okay?
Mm-hmm. Yes.
Yes.
Go ahead, Brian.
Mark, you can? Okay, great. Okay, Mark, I'm on the cover page, slide 25. Do you want me to share my screen, and that way they can see my cursor?
If we can do that, I don't.
If you go back to the Zoom,
Okay.
is it projecting what's on that computer screen?
No, I don't think it is.
You're gonna break
I
it.
don't.
Not-
You know what, Brian? I don't want to screw it up. Just tell me when to switch, and I'll switch the slide.
Okay. It says I'm sharing my screen right now.
Oh, wait a second.
In the little box.
Do I click on that?
See the bottom right-hand corner where that little green arrow is?
This?
Click on that, make it full screen. There you go. Now we can see his screen.
All right, Brian, it's all yours. I'm going to sit down.
Yep. Make it bigger. Make it full screen.
Okay. Hi, everyone. Good afternoon. So, yes, Jonathan was up there speaking. His information was, I think, paid through March of 2020. What you'll see as we go through this, and it's on the bottom left-hand side here, very small.
Brian, can you make that full screen?
Let's see here.
Oh, you can?
He just had it.
Is that better?
Yeah, that's better. Take the participants off. If you click at the bottom.
Looks like there might be a delay on the YouTube. If you can see that better. Yeah, so as you'll see here on the bottom, it shows that the current period is October of 19 through September of 20, the most recent rolling 12 months, and then the base period will be October of 18 through September of 20. Okay, so looking at the section in blue, the navy blue section here, you can see just real quickly the highlights. I know we're probably don't have too much time here. You can see that your membership from last year to this year is down just about 1% year over year. Your demographic factors, your age did go up a little bit from last year to this year. Demos went up. Demographics, that is. The actual medical spend in total, medical and pharmacy combined, is only up 2.5% from last year to this year. You can see that the medical component is up just 1% from 58.1 million to 58.7 million. Spend is up from 15.7 million to 16.9, almost 17 million. So that's up 8%. So combined, it's the 2.5%. Adjusting for the membership changes up above on a per member per month basis, in total, you're up about 3.4%. As you can see, in total, the $545, 18 cents per member per month is about significantly lower than other school board norms for Cigna across the state of Florida. And then you can see you did have an increase in your 1,000 members by about a 15% increase from 7.1 per thousand up to 8.2 per thousand. Their actual spend is up 17%, and we'll see some of those high claimants and which driving some of your high claims costs. But then if you look at your non-catastrophics, those enrollees who have less than and spend is actually down about 1% per member per month for both medical and pharmacy combined. And as far as in-network penetration, that looks really good too. You're at about a 97% in-network penetration. And looking on the right-hand side, lower right-hand side, in the population health and pharmacy, you can see about 46% of your population has a chronic condition. They represent about 76% of your spend. That's a little bit lower than other school boards. So that's good to see. Engagement's about 55%. That's actually higher than other school board norms. Although it's down from last year, it's still above the norm. It's not a too bad situation. Preventive care utilization, at least through September, is about 53%. That'll probably move closer to the 60% norm for the year. And well-visit completions is about 43%. And you can see that your gaps in care rule compliance, following evidence-based medicine guidelines, 81% of the time, which is above the norm as well. So that's another good statistic. And then your generic dispensing rate that we're showing through September is about a 92% generic dispensing rate now, which is above the norm and also about a 1.6% increase from last year. Okay? You can see the huge increase here on specialty for both pharmacy, that's up about 19%, and for the specialty in medical is up about 39%. And, usually Kelly Monzilla will drill down on that for us during the quarterly reviews. And I think we heard that a lot of that from the last time she spoke was somewhat related to the cancer that we have in the plan. So looking at the following page, just your demographics and your population, you can see that about 52% of your membership is over the age of 40. That's on the upper right-hand side here. The average member age is about 37 and a half years old. Average employee age is just under the age of 49. And you have about 37% of your enrollees are male and 63% female. And no surprise, we always see this by age band. The older come in the 65 plus actives on the plan is costing you the most money at $1,130 on average. That's up about 5% from last year. And it looks like the next highest is the 60 to 64. Even if we exclude the catastrophics, the 65 plus is the highest age and up about 6% from a year ago for all of those that are 65 and over and under $100,000 in paid claims. Looking at it by relationship, as far as employee, spouse, and dependent, you can see that the spouses are the most expensive relationship in total, including the catastrophics at $820 versus $817 last year. The employees are costing you about $648 on average compared to $626 last year. It's up about 3.5%, but they're norms that we're seeing for other school boards with Cigna. And then you can see the dependents are coming in at $288 on average per dependent it was about a 5.7% increase. And excluding catastrophics, the spouses are still the most expensive relationship at 5 on average, although it's less than what we were last year at 573 and below the norms. Okay? As far as what's driving your trend, you can see on the bar graph here, your catastrophics is really what the most, the area that's really driving most of that trend. It's over on the right-hand side here at 3.6%. We did say on the previous page that your catastrophics are increasing significantly from last year to this year, about a 17.6% increase PMPM. If you look up above, the non-catastrophics, you're down about 4% overall per member per month. Okay, then so when you combine both of those together, you're up just about 2% on the medical. The member cost share went up just a little bit, by $1 per member per month. So combined, that makes that a total increase on the medical just under 2%. Cigna's medical trend is running about 7% in the marketplace, so you're well below what we would typically see in this marketplace for trend. And you're also running, if you look over to the far right-hand side here, significantly lower than other school boards as far as what the net to you, the employer, paid out per member per month, significantly lower than other school boards. As far as pharmacy spend, you're at $122 per member per month. It's up 9% from a year ago. It's boards at $124. The member cost share that the employees pay out of pocket for their pharmacy costs is running about $19. The norm is $11. And you can see net to you, the employer is $104, and the school board norm is $112. So you combine all of this together, you're paying out about $500 per member per month. It's up 3.4% in total, medical and pharmacy combined. And again, typical medical and pharmacy trend combined is about 7%, 7 to 7.5. So you're looking pretty good from our perspective through September. By condition, you can see the most costly diagnostic areas as cancer is your number one area. It did go down just a little bit from last year and well below the norm of $90 for other school boards. If you go across this line, catastrophics, claimants per 1,000 rather for cancers is actually down 6% from last year to this year. So you have less cancer claimants than you did a year ago, and the cost is about the same. And you can see the total spend per claimant on average is about $73 versus $3,171 last year. It's about a 6% increase. Your second most costly condition through September of 20 is musculoskeletal. It's at about $55 now per member per month. The norm is $58. So you're a little bit better than norm. You're down 2% from a year ago, and your claimants are down about 5.7% from a year ago that have musculoskeletal issues. The cost is also down about 6.7% from last year, down to about $2,153. Then you can see the top 10 here. You have gastro, general medical diagnostic, circulatory, and then you have infection, parasitic, neurological, pregnancy, endocrine, and reproductive. That rounds out your top 10. If you look at all of these in total, you're coming in a trend of about 1.4%. From last year to this year, the norm's 501, so you're well below the norm. Your actual number of claimants did increase by only 0.4% with these conditions, and your cost on average has gone up about 1% from $4,800 to $4,851 from a year ago. So not too bad, really, from last year to this year. Looking at your catastrophic claimants, we did mention did have an increase in the number of claimants per 1,000. The typical high claimant is now running you about $200,000, almost $201,000 on average. Last year, they ran you about $187,000. The school board norm's about just under $237,000. And then on the upper right-hand side, you can see which by component was driving these high claimants. The outpatient costs went up significantly from last year to this year by 35%. The professional component, which is what we pay out to the physicians, the actual doctors themselves, is up about 15%. And other, that's a lot of that is the home health, home infusion, durable medical equipment, medical injectables, things of that nature run through this. And a lot of that cancer care is what's causing some of that. You can see cafeteria 6 cents and pharmacy is up 12.2% on these catastrophics. So that's where the 17% increase is coming in from on the catastrophics in total. You combine that with the non-catastrophics at minus 0.8% from last year to this year, and you're really coming in at 3.4. Okay. This is a summary of your top 25, and we were asked to black out the male, female, the gender, the age, and the relationship. But I think when I went through here, I counted up about 10 of the 25 are cancer patients. Your number one, what's also important to note, the third column from the far right-hand side tells you the last month that they were eligible for the plan. The very top person, that's infection that costs $854,000. The last month they were eligible in our system was back in July. So as of August 1st, they're no longer on the plan. So you're no longer going to have any more ongoing claims for that person. The third one is also no longer on the plan. Their last month, March. Number 5 was no longer on the plan. Their last month was in August. And I think if you go down here, I think it was number 13, if I'm not mistaken. Yeah, it was number 13 was last month was in June. So you have about 4 or so that are no longer on the plan going forward. And then the column just to the right of that tells us if they were a catastrophic claimant last year or not, yes or no. And most of these were not high claimants last year. A few of them were, but not as many. And then as you just kind of go down through here, you get that they have and what types of cancer that they have as well in this ICD minor column. Okay, just going to give you an idea of what's driving your high claims costs from last year to this year. Okay, as far as you did hear somebody, I think it was might have been Chris was asking about the urgent care utilization. So we'll see a little bit of that on this screen. The non-steerable at the very top line, the non-steerable ER visits were visits to the emergency room that really couldn't have been seen anywhere else. They really were somewhat significant. They could not have gone to an urgent care. That's actually down 9% from last year to this year. And the cost is down 1% from almost $2,400 down to $2,380. On a PMPM basis, that's if you look at the steerable, these are the ER visits that showed up that the conditions weren't really that severe to where they possibly could have been seen at an urgent care facility. When we break this down for you, the good news is those are down 10% from last year to this year, so they're not going as much as they were in the past for conditions that are not that severe. It's still costing Brevard Schools about $790 on average for those visits, although that's down 9%. We break that down for you in the table below. That $790 comes from this table below for the 160 visits that did show up at the ER that possibly could have been seen in urgent care. And by the way, these 160 visits, those people live within 5 miles. 97% of them live within 5 miles of an urgent care facility. The number one area of these visits at the ER that could have been seen in urgent care was musculoskeletal. ENT was your second highest with 29. It cost you $706. And then third highest was skin conditions, if you will. The difference here between $790 and the $122 at an urgent care facility for these that went to the emergency room could have saved you about $667. So if just 25% of them could have been steered to urgent care or would have gone to urgent care, it would have saved about $26,710. So if 100% could have gone to urgent care, it would have saved about $106,000, almost $107,000. Just take this number times 10. Okay. Spent this year about 2.1% of your total dollars in the plan was spent on preventive care. That's down from 2.3% last year, and just a little bit lower than other school boards that we have with Cigna at 3.2%. You can see on the right-hand side, the upper right-hand side, the children have had their well, 7% of them have. It's down a little bit from last year and below the norm. And about 38% of the adults have their well visit completions. You do have some really good cancer screening results on the bottom left-hand side. If you look in the blue comment section at the very bottom, we're using the HEDIS measures for this criteria. So you have to be in the plan for 24 months with Cigna and be in these age bands for these conditions. And then we look into the system to see if you've had your breast cancer screening or cervical cancer screening. See, for breast cancer screening, you're running at about 68%. Have had their screenings per the HEDIS measures guidelines through September versus 63% norm. Your cervical cancer screenings at 63%. versus a norm of 60%, and their colon cancer screenings come in at 44 versus a norm of 51%. So that's a real good area that we could probably focus on moving forward, which I know you do during your educational programs and wellness programs. But that's the only area here that's below the norm. As far as virtual care, some really good numbers, some increases here. On the upper left-hand side, you can see the types of visits from last year to this year that you had. Per 1,000 members, you had a nice increase in ear, nose, and throat visits. Renal urologic was the next highest area for the telehealth visits. Respiratory was number 3, a huge increase probably because of COVID. And then infection and parasitic was your next category. Looking at all of these in total, last year we had about 295 unique members with one visit to telehealth. That jumped to this year to 577 individuals that had at least one telehealth visit. Last year there were 66 unique members with 2 visits. This year that jumped to 173 members, and then last year we had 34 with 3 or more telehealth visits, and this year that jumped to 103 unique members with 3 or more telehealth visits. So it's nice to see that increase. Those members that did use telehealth, it was about 6.7% of the population. Their average age is just under the age of 40. Those people, 51 telehealth visit, also had a primary care office visit during the same time frame. It was 17% male and about 18% male, I guess, and 82% female. The males were about 33 years old and the females were 41 years old on average. For instance, the cost difference between a regular office visit, a steerable ER visit versus a virtual care visit of only 55. So if we could just redirect some of those prior visits we were talking about earlier, just 25% of those would be savings to Brevard Schools of about $229,000. Looking at just pure office visits to the physician's offices, if just all of those could have been steered to telehealth, would have saved Brevard Schools about $145,000. But there's still significant usage, so that's good to see. And that'll just be continued savings for you as we go on further each year. Okay. Looks like this slide is in here twice, right? Yeah, it's in here twice for some reason. Utilization management, just real quickly, there's about 6 or 7 more slides. This is the utilization management programs that Cigna has. So last year we had savings for you of about $302,000. This year, $851,000. Most of those coming from admissions avoided, which saved about $731,000. And the common sections in blue, looks like there were 27 admissions that we were able to avoid and probably do the procedure on an outpatient basis instead of inpatient. That's $1,000. And 25 days were decertified days, and about 21 days were step-down days, from ICU down to a regular bed day, if you will. Okay. As far as outpatient utilization management, you can see there were some savings. Last year we had $30,000 in behavioral, none this year in that category. $631,000 rather savings in high-tech imaging versus $527,000 savings last year in high-tech imaging. Medical injectables was about $488,000 in savings on 31 injectables that were avoided. We had a lot of savings in the total medical cost management of $652,000. And then we had all other savings, so $2.2 million in savings this year versus $1.8 million. That $652,000, which is where most of the savings came from. There's a bar graph here. Most of that comes from your sleep therapy savings, radiation therapy, and musculoskeletal pain management program. And we detail that out for you. I think, well, there was another slide that shows how much savings it was. I think we took that slide. It comes from sleep therapy. And then all of the programs combined that you have with Cigna, your inpatient, outpatient utilization management, your chronic condition coaching, specialty case management, all these programs combined together has saved Brevard Schools through September, October of 19 through September of 20, about $5.4 million. Okay? Then we have a summary page for you here on COVID-19. Through September 30th, that 1.3% of your total membership had a prevalence rate, actually tested positive for COVID. On the right-hand side, the prevalence rate tested was 9.3%, so 1.3% of your membership 9.3%. Out of that 11,571 total members, the 1,641 was tested, the 143 were diagnosed as positive. So that first one was really 1.3% of the total membership. The average age is 39 years old, 91 employees, 16 spouses, and 46 dependents were diagnosed as having COVID. That was 33% male, 67% female. Okay, and through September, total spend on testing has been $159,000, just over $159,000. That's coming out to $100.15 per member per month. The total treatment cost is coming in at $76,833 at 55 cents PMPM. And Mark, we looked yesterday at how many admissions we had through September, and we had 6 people who tested positive that were admitted with COVID-19 through September 30th. And you can see that of the diagnosed members, obviously if you have a comorbid condition, it's going to put you more susceptible and more at risk of catching or contracting COVID-19. And the 5 top chronic and comorbidities for those people that were tested was asthma, metabolic immune disorders, obesity, diabetes, and hypertension of those that were diagnosed. We also looked at how many people had been hospitalized through October 24th, just a few days ago, and I think we're up to 10 employees now, or not employees, 10 total members who have tested positive have been hospitalized before, and that's up from 6 people through September 30th. Okay. So taking that information and looking at the COVID-19 reporting in a different way, we looked at your entire population across the country, but most of your membership's in Florida, so we're just going to concentrate on the 98% of your enrollees who are in Florida. And as you look on this bottom left-hand side here, it does speak that if you're high risk to your group, means that 30 members have at least one risk factor, and I'll show you the risk factors in just a moment. A moderate risk would be about 16 to 30% of your members have at least one risk factor per the CDC. And then low risk would mean that 15% or less of your members would have one, would be considered low risk. So looking at your specific information, these are all of your members in Florida only, 11,126. 72.1% of your employees had at least one of these risk factors at the bottom here. And you can see those, hopefully: serious heart circulatory conditions, compromised immune systems, a smoker, diabetic, chronic lung disease, liver disease. All of these risk factors are considered one of the conditions that would in COVID-19. Again, 72% of the employees had at least one of those factors at the bottom. Out of those employees that had at least one risk factor, 31% had one factor. 21.6% of that 72% had 2 risk factors. 20% of your employees, the 72% of the employees that had 3 or more risk factors of that 72%. And then looking at your members, 54.1% had at least one risk factor, and that 54% breaks down to 25.4% had at least one risk factor only, 15.2% had 2 of these risk factors below, and then 13.6% had 3 or more of those risk factors listed below per ship. And then you can see, of course, 46% of the members had no risk factors, and of the employees, about 28% had no risk factors at all, as far as the CDC information. So taking all this information together, we look at the information in risk clusters, and we put it into 4 different quadrants: A, B, C, and D. And on the left-hand side, you can see A is mitigation, B is work from home, which it looks like for Bard Public Schools is in the B quadrant. For we're saying that you should continue to still work from home if you're able to do so. C would be high risk work from home, which you're not in high risk. And what we want to see, and we think we will, obviously eventually over time, is see these bubbles migrate over to quadrant D, which would be potential return. So we'll run this for you each month and forward this out to you, Mark, and you can send it out to the committee if you like. But we can update this about once every 30 days or so. And again, on the bottom left-hand side of this page, it tells you what the CDC considers to be high risk versus risk. And with that 31%, I'm sorry, of your employees and 25% of your members being in at least one risk factor, you can see that low risk was less than 15%. So moderate risk was 30% of your members, and high risk was 31% of your total members, and you're not quite there. You're 25.4% of your total members have at least one risk. So you would be what we would call in the moderate, right here, okay? Sorry, I keep flipping back and forth, but that's too confusing. And really, that's it for me, unless you have any questions.
Anthony, go ahead.
I noticed on the MyCigna website that you can get a COVID test mailed to you. I know that we're encouraging our teachers to test with the Department of Health because I believe that's no cost. But as far as that test that can be ordered and delivered from the MyCigna website, is that a better cost option to our plan versus them going to their doctor or elsewhere to be tested?
I think it would be, but I don't have any details on that, those mail-in tests. So let me take that away and see what kind of options we have on that. Unless, I believe Corey might be on the line with me from information on that I'm not aware of. I would have to take that back and see what our options are for that. Was that Anthony?
Yeah, I don't know if you, Brian, I mean, it's there now. It's available. I'm not asking for it to be available. I don't know if I was clear about that. It is available. I know employees who have used it. I just want to know if it's a cost-effective way to be testing.
Okay, I will definitely research that for us and get back to you. Absolutely.
I'm assuming that test is probably not as accurate as getting, the nasal swab, and that's probably why we as a district want people to get the nasal swab.
I think it might be a nasal swab.
Yeah, but who's going to self-inflict that?
The test coming from Cigna?
Yeah, you go to MyCigna and you can get a kit mailed to you to be tested, and it's a swab.
Makes more sense that they would have you do your own nasal swab than some kind of a blood draw or something.
Yeah.
I'll look into that too. All right, thank you, Brian.
Thank you, Brian. Is there anything else for the next part, Mark? Comments, suggestions?
Thank you, everyone.
I don't have anything right now except we're just fielding a lot of calls and trying to answer a lot of questions this week through open enrollment. I have sent you.
Corey Narbutas. Can you hear me?
Yes, go ahead.
Hi, yes.
I think we lost you. Do you have anything to add?
Sorry about the delay, everyone. But yes, the nasal swab for COVID, you can get that requested on MyCigna, and that is. Yeah, sorry the delay. They can request it on. They have symptoms, or if they have been in contact with someone with COVID, and it would be shipped to their house. So that is the rules really for any COVID testing right now, which has been extended to end of January for free testing, and the treatment for COVID is extended through the end of December.
But is it costing the plan?
Corey, do you know how much that test costs compared to what we're paying when somebody goes to one of the local testing centers or into a clinic or a hospital?
Cost of the plan, I have to take it back. They're all around the same prices, but we can take that back. The specific cost.
So that's we'll report that back. I think I was just finishing up. We're just fielding a lot of calls. I have been sending out the communications for open enrollment this week. I'll send out another one on Friday, so you'll see what's gone out. We've had pretty good response at this point. We're actually ahead of where we were this time last year on people who have gone in through open enrollment. We're not fielding a lot of questions in my office, at least, and with the benefit specialists on how does this plan work compared to the other. So I know that you had said earlier that people have some confusion. We haven't had a lot of those. A lot of the questions have been spousal surcharge related. That's what I hear a lot, because they want to make sure they're not going to be charged $250 a month. And so they'll enroll and then they'll send an email saying, can you verify that I'm not going to be charged the spousal surcharge? So I think that's what a lot of people are fearing. And like I say, I haven't heard a lot of fear of how these plans operate. I will get back with AFLAC to find out what their counselors have experienced with regards to questions in those areas as well. But I think open enrollment is going well. Obviously, we have 2 days to go, and so we'll see where that ends up. And once that's done, I'll be able to report back the statistics to you on how many enrolled, how many didn't enroll, how many went into the gold plan, how many of the silver plans, and I can do that for all of the other areas that we're doing as well, for dental, FSAs, vision, and long-term, short-term, and AD&D, et cetera. I did send out the link to anybody to look in Easy Benefits. I mean, Dominic said he went through it. And
The Easy Benefits was just as it's titled. You click from one format to the next, medical, pharmacy, all the information's there. If you go through it logically, you can make a decision very easily.
And the good thing about Easy Benefits is it will not let you progress until you have answered every question, clicked every box to actually get that final printout, which is nice.
I have a question on our silver plan, because as I got that, how did we end up with a silver plan that's not the narrow network that we originally discussed?
Well, it is a narrow network in Schedule 1. So that's, what we didn't want to do is because we still have access to in-network pricing from Cigna, to put people completely out of being able to go, you know, if they must, or if they accidentally go to a Health First hospital or a Health First physician, for example, by completely putting them out of the network, that would be, I think we initially just decided it would be best to allow them to do it, but they would have to pay more for it. Because if you look at the stats, 97% of our people, of our employees, are choosing in-network providers. So I'm thinking Schedule 2 will not be utilized very much, because it's the same pricing on the Schedule 2 plan as our current costs. So I think most people will stay with the Schedule 1.
Was there a cost impact to the plan for including Schedule 2?
No. It's not, it was immaterial. That's what
Okay.
I heard from that. Did you guys happen to look in the EasyB or have any other questions regarding the plan?
That was another misconception. People thought that was two different plans.
Oh, yeah.
They thought the Schedule 1 Silver and Schedule 2 Silver were two different plans, and then they get confused on Easy Benefits, like, why can't I choose? Why can't I choose?
Well, and then a lot of people also thought they couldn't go to the wellness clinics anymore.
Mm-hmm.
And on the handouts that came with our passwords, down at the bottom was the pharmacy section. And because the columns lined up, they thought that also the pharmacy changed and applied to what was above. I said, no, pharmacy's
That's completely separate.
different.
Well, and if you look in the plans, you know, I don't have it in front of me, but our clinics are listed as no cost. So I'm not sure. People weren't reading
mill.
it.
That's exactly what it is. It's rumor mill and misconceptions, and unfortunately, some of those rumors are being started by supervisors at work sites.
Really?
So, yeah, so there's a problem.
Well, I can say this, when I had because I had a session, you guys if you want to go back and listen to it, it's online.
It didn't work.
Yeah, but I'll verify that, Leslie. I'm not sure why it's not working for you, but
Just tried it.
we did it a little differently this year due to COVID-19. So we would normally hold those meetings here where we meet with each site benefit contact and go through the plans. This was a shorter meeting. Obviously, you can see how long it was, just a little over an hour. And most of those who listened thought it was great because they got better information out of that in a shorter period of time. And I've had more people come up to me as I walk around this building saying, Mark, this is the best year we've had for education. So they've liked it so far. I was hoping that would, bleed down to everybody on the local level, and obviously we need to work on our supervisors. We did invite the principals to attend. The day of that training, though, the secondary principals were at a training at Cocoa Beach Junior Senior High School, so they didn't attend, but quite a few of the elementary principals did. So hopefully they got something out of that.
Lisa's voiceover PowerPoint was very well done.
Yeah, absolutely. Thank you, Leslie.
She's answering.
And that's all I have.
Is there anything else for the good of the group? If not, do we have a motion to adjourn?
Oh, let me say one thing first. We had scheduled our next Siac for December, was that 7th? I don't have my calendar in front of me, but we've had to move it to the 16th because this room was taken. So we'll do December 16th. I will send out an invite for everybody on that date. I'll probably do it this next week. We don't generally hold a meeting in November because of the holidays, and then trying to do it the fourth Thursday of December wouldn't work. So the 16th is the best day for us. So I will send an invite for that.
Okay, one more request for a motion to adjourn. So moved. Do we have a second? Yes. Everybody have a great afternoon. Travel safely home. Thanks for coming.
Thank you.
See you in December.